Thank you. Good afternoon, everyone, and welcome to the Assembly Committee on Health and Human Services. At this time, I will go ahead and call this meeting to order. Madam Secretary, can you please call the roll?
Assemblywoman Benitez Thompson. Assemblywoman Black.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Hafen.
Here.
Assemblywoman Krasner.
Here.
Assemblyman Matthews.
Here.
Assemblyman Orentlicker. Assemblywoman Peters.
Here.
Assemblywoman Summers Armstrong.
Here.
Assemblywoman Thomas.
Here.
Assemblywoman Titus.
Here.
Chair Wynne.
Here. And I see Assemblyman Orentlicker on the screen. I don't know if he was having some issues, but I do see him present. Assemblyman Orentlicker, oh, there you are.
I was muted.
Just wanted to make sure I know that the computer ghost might be out and about. So I just want to make sure we're all present. It looks like everyone is present except for Assembly Member Benitez Thompson. And so if we can just mark her present when she arrives. I know that there are people presenting in other committees right now. So there is that. So with this, we will begin first on the agenda. We have a work session and one bill hearing. So at this time, I will start with the work session. If we can go first to Assembly Bill, I'm going to take them a little bit out of order because I know people have to get back to their other committees. So if we can start with Assembly Bill 348. Mr. Ashton, can you please summarize the bill and any amendments?
Thank you, Madam Chair. For the record, Patrick Ashton, Committee Policy Analyst of the Legislative Council Bureau. Just my usual reminder, as nonpartisan staff, I can neither advocate nor oppose any measures that you will consider today. So we will begin the work session with Assembly Bill 348. We heard this bill last Monday. The bill transfers the Patient Protection Commission from the Office of the Governor to the Office of the Director of the Department of Health and Human Services and revises the membership of the Commission. The bill also requires the members of the Commission to comply with certain requirements regarding disclosure of conflicts of interest and abstention from voting when certain conflicts arise. Amendments. Assemblywoman Maggie Carlton proposes the following amendments to the bill, and she also attached a revised conceptual amendment. Amendment 1. Remove any provisions related to the establishment of a Patient Protection Commission Advisory Committee and an all-payer claims database. Excuse me. Amendment 2. Restore the existing duties of the Patient Protection Commission that are deleted by the introduced version of the bill. Amendment 3. Revise the membership composition of the Commission to provide that one member who is a provider of healthcare must be experienced in running a healthcare for-profit business, and B, one member with expertise in healthcare information technology and patient access to medical records who must be either an employee or consultant from DHHS. Members, I would like to clarify that this amendment does not add any new members to the Commission, but instead revises existing provisions in the bill related to membership composition. This amendment was revised after the bill hearing last Monday. I'll continue with Amendment 4. Authorize the Commission to establish any subcommittees or working groups as necessary. Amendment 5. Require the Commission to adopt bylaws governing its own operation. Amendment 6. Provide that the Commission members serve at the pleasure of the Governor, thereby allowing the Governor to remove members at will. Madam Chair.
Thank you, Mr. Ashton. I would note that one of the significant amendments I think that came out of at the conclusion of the hearing, and I know we have Assemblywoman Carlton here, is she did take the suggestion of Assemblywoman Titus in including membership for a for-profit provider. I don't know if Assemblywoman Titus saw that, but I just wanted to point that out. She is available for questions. So at this time, do any of the members of the committee have any questions?
Comment, Madam Chair?
Go ahead, Assemblywoman Titus.
So I absolutely appreciate Assemblywoman Carlton's addition of a for-profit person on the board. I think that is very helpful with getting appropriate data and appropriate input on this commission. And I absolutely want to acknowledge Assembly Carlton's listening to my suggestion on the amendment. I wish that that was the only issue that I had with this bill. I'm still having some of my healthcare folks that I rely on are still having some angst on this. So I'm just going to let her and you all know that I'm going to vote no on this. But if I can get reassurance from them that they will accept the bill, I may change my vote on the floor. But at this time, I'm still going to be a no until I get some other communications with healthcare workers.
Thank you. And I would note for the record that Assemblywoman Benitez Thompson is now present. She logged on right as we began the work session. Do I have any other questions from the committee? Seeing none, I'd entertain a motion at this time on Assembly Bill 348.
So moved.
Do I have a motion or a second on that amend and do pass motion? And a second from Assemblywoman Benitez Thompson. I will be doing a roll call vote because I believe that we have some divisions, so I want to make sure the record is clear. Madam Secretary, can you please take a roll call vote?
Assemblywoman Benitez Thompson.
Yes.
Assemblywoman Black.
No.
Assemblywoman Gorlow.
Yes.
Assemblyman Hafen.
No.
Assemblywoman Krasner.
No.
Assemblyman Matthews.
No.
Assemblyman Orendlicher.
Yes.
Assemblywoman Peters.
Yes.
Assemblywoman Summers Armstrong.
Yes.
Assemblywoman Thomas.
Yes.
Assemblywoman Titus.
No.
Chair Wynne.
Yes. And with that, the motion passes, and at this time I will assign that floor statement to Assemblywoman Carlton. Next, if we can move to Assembly Bill 287. Again, I'm taking these slightly out of order. I know people have to get back to their committees, and I see Assemblywoman Danielle Monroe Moreno in our Zoom call, so I want to make sure I call her bill next. Mr. Ashton, can you please summarize that bill and any amendments?
Thank you, Madam Chair. For the record, Patrick Ashton, Committee Policy Analyst. We heard Assembly Bill 287 on March 31st, and the bill provides for the licensure of freestanding birthing centers. The bill makes various other changes related to freestanding birthing centers to ensure that they perform certain screenings and report certain information required to be performed or reported by other licensed facilities that provide health-related and pregnancy-related services. Assemblywoman Danielle Monroe Moreno proposes to amend the bill as follows. See also the attached proposed amendment AB 287. Amendment 1. Revise certain chapters of the Nevada revised statutes to replace the term mother with the term birthing person, and authorize the legal division of the Legislative Council Bureau to make conforming changes throughout NRS as necessary. Amendment 2. Add a certified personal midwife and a certified nurse midwife as providers of healthcare throughout the bill, wherever midwife is mentioned, and authorize the legal division of LCB to make conforming changes throughout NRS as necessary. In Section 12, Amendment 3, revise subsection 1A to require any regulations adopted for the licensure of freestanding birthing centers to be aligned with standards established by the American Association of Birth Centers and the accrediting body of the Commission for Accrediting Birth Centers or any other approved national accreditation body. Amendment 4. Revise the requirement prescribed in subsection 2 to instead provide that a freestanding birthing center must be located within 30 miles of a hospital that offers obstetric and neonatal services relating to pregnancy. Amendment 5. Add a new subsection authorizing a freestanding birth center to serve as a supervised training facility for certain providers of healthcare. And the bill also provides for certain other amendments as outlined on the bill page. Madam Chair.
Thank you. I'm going to put this in view. Are there any questions from committee members?
Comment, Madam Chair?
Do you have a question or do you have a comment on the motion?
Just a comment.
Can I just make it until it's in the comment section? I will have you an opportunity to do so. Do we have any other questions though? Okay, at this time I would entertain a motion to amend and do pass Assembly Bill 287.
Amend and do pass, Sarah Peters.
I have a motion from Vice Chair Peters. Do I have a second?
Second,
I have
Assemblywoman
a second
Gorlo.
from Assemblywoman Gorlo. And now at this time I will take any comments on the motion. Assemblywoman Titus, go ahead.
Thank you, Madam Chair. I absolutely am supportive of freestanding birthing centers. I do appreciate the comment during the hearing from Assemblywoman Peters that a woman should have the right to choose where they birth a child. And I also believe where they send their kids to school, but that's another issue. But my biggest heartburn with this bill is the fact that they can be 30 miles away from a obstetrical center, having delivered children and have seen many an emergency, even because as a family practitioner, I only delivered low risk mothers. And so having seen disasters that can happen in that group, knowing the importance of having an assistance close by, I unfortunately will have to be a no on this bill. Thank you, Madam Chair.
Do I see any other comments from committee members regarding Assembly Bill 287? Seeing none, at this time, I would ask the Madam Secretary to do a roll call vote.
Assemblywoman Benitez Thompson,
Yes.
Assemblywoman Black,
No.
Assemblywoman Gorlo,
Yes.
Assemblyman Hafen,
No.
Assemblywoman Krasner,
No.
Assemblyman Matthews,
No.
Assemblyman Orentliger,
Yes.
Assemblywoman Peters,
Yes.
Assemblywoman Summers Armstrong,
Yes.
Assemblywoman Thomas,
Yes.
Assemblywoman Titus,
No.
Chair Wynn.
Yes, the motion passes, and I will sign that floor statement to Assemblywoman Monroe Moreno. With that, I will move on to our next work session bill. And again, I'm going out of order. I'm going to Assembly Bill 256. Mr. Ashton, can you please summarize the bill and any amendments for the committee?
Thank you, Madam Chair. For the record, Patrick Ashton, Committee Policy Analyst. We heard Assembly Bill 256 on March 24. The bill requires a doula who desires to provide doula services for a Medicaid recipient to register with the Division of Healthcare Financing and Policy of the Department of Health and Human Services. The director of the department shall include in the state plan of Medicaid a requirement that the state pays certain costs for doula services provided to Medicaid recipients to the extent authorized by federal law. The department shall apply for a waiver of federal Medicaid requirements or request to amend the state plan to receive federal funding to provide coverage of doula services. Amendments. Assemblywoman Summers Armstrong proposes to amend subsections 3 and 4 of Section 1, 2, and see also the attached amendment. Amendment 1, remove the requirement that the division adopt regulations prescribing the required training and qualifications for registration as a doula. Amendment 2, revise requirements relating to persons who wish to receive reimbursement through the Medicaid program for doula services and require such persons to submit to the division an application for enrollment in Medicaid and include with the application proof of certain training and qualification, and make conforming changes to the definition of registered doula to reflect that these persons are enrolled with Medicaid rather than registered by the division. Amendment 3, remove provisions authorizing the division to charge a fee for registration of a doula, thereby removing the requirement that a 2/3 majority vote is required for the bill. Madam Chair?
Thank you. At this time, do any of the committee members have any questions regarding the bill? Looking here. Seeing none, at this time I would entertain a motion on Assembly Bill 256 to amend and do pass.
So moved. Assemblywoman Gorlow?
I have a motion by Assemblywoman Gorlow. I see a second from Vice Chair Peters. Do we have any comments on the motion? Seeing none, I will go ahead and ask Madam Secretary to do a roll call vote.
Assemblywoman Benitez Thompson,
Yes.
Assemblywoman Black,
No.
Assemblywoman Gorlow,
Yes.
Assemblyman Hafen,
No.
Assemblywoman Krasner,
No.
Assemblyman Matthews,
No.
Assemblyman Orentlicker,
Yes.
Assemblywoman Peters,
Yes.
Assemblywoman Summers Armstrong,
Yes.
Assemblywoman Thomas,
Yes.
Assemblywoman Titus,
No.
Chair Wynne.
Yes, the motion passes. At this time, I will assign that floor statement to Assemblywoman Summers Armstrong. One second while I catch up here. Next, if we can go to Assembly Bill 374. Mr. Ashton, can you please summarize the bill and any amendments?
Thank you, Madam Chair. For the record, Patrick Ashton, Committee Policy Analyst. We heard Assembly Bill 374 last Monday. I will go straight to the summary of the proposed amendments. Assemblywoman Toles proposes to replace the introduced bill with the following provisions, and see also the attached conceptual amendment. Amendment 1, create the Nevada statewide substance use response working group within the Office of the Attorney General. Amendment 2, require the Attorney General, Senate Majority and Minority Leaders, the Speaker of the Assembly, and the Assembly Minority Leader to appoint members to this working group. Amendment 3, prescribe the duties of the Nevada statewide substance use response working group, which must include certain requirements as outlined on the bill page and the conceptual amendment. Madam Chair.
Sorry. Are there any comments at this time or questions about the bill? I know that Assemblywoman Toles is on this call, and I believe there was a further amendment that didn't make its way into the work session document. So I will allow her at this time to make that orally. Assemblywoman Toles, can you unmute yourself and make those representations?
Yes, Madam Chair, thank you so much. And thank you again to this whole committee for hearing this bill and for the support. I just wanted to recognize that there were some individuals who wanted to add on as co-sponsors, and I apologize that that didn't get through into the work session document. So Senator Ratty and Assemblywoman Thomas, Peters, yourself, Madam Chair Wynne, Assemblyman Hafen, and Orentlicker all wanted to add on as co-sponsors. And of course, if anyone else would like to join, I'd welcome anyone as well.
Thank you. Thank you for that clarification. Are there any further comments from committee members? Or questions, I should say. Seeing none, at this time I would entertain a motion to amend and do pass with the additional amendments of those listed co-sponsors.
Amend and do pass.
I have a motion from Vice Chair Peters. Do I have a second?
I'll second. Assemblywoman Gorlow?
Thank you, Assemblywoman Gorlow. Are there any comments from committee members before we move on?
Madam Chair.
Go ahead, Assemblywoman Summers Armstrong.
Thank you, Madam Chair. If I may, do we have to, if I want to be added on, should I have done it before the motion? I wasn't sure about comments.
I'm sure we could amend you on during the amendment process when we're moving through here. I'm sure Assemblywoman Toles would accept you as a co-sponsor as well. And I would encourage anyone else during the next couple of days, if you've decided that you were not included on that list, I'm sure if you reach out to Assemblywoman Toles, she will make sure that you are included. Do I have any other further comments on the bill? No? Seeing none, Madam Secretary, can we do a roll call vote?
Assemblywoman Benitez Thompson,
Yes.
Assemblywoman Black,
Yes.
Assemblywoman Gorlow,
Yes.
Assemblyman Hafen,
Yes.
Assemblywoman Krasner,
Yes.
Assemblyman Matthews,
Yes.
Assemblyman Orentlicker,
Yes.
Assemblywoman Peters,
Yes.
Assemblywoman Summers Armstrong,
Yes.
Assemblywoman Thomas,
Yes.
Assemblywoman Titus,
Yes.
Chair Wynne.
Yes, and that motion passes unanimously, and I will assign that floor statement to Assemblywoman Toll. And with that, that ends our
Wynne?
work session.
May I ask a question, please?
Oh, go ahead.
Just a clarifying question. Assemblywoman Summers Armstrong was she included in the motion right now to be added as a co-sponsor to the bill?
You know what? How about we do this? Assembly Vice Chair Peters, I think you made the motion. Do you have any problems including that motion, her in that motion to amend and do pass?
I intended to include the addition of Assemblywoman Summers Armstrong as a co-sponsor in that motion.
Okay, and do we have a second
And
Assemblywoman
Madam
Gorlow?
Chair, sorry.
Go ahead.
Assemblywoman Gorlow just asked if she could join as well. So if we could just not have to do this twice, if that's okay, if we could add both Summers Armstrong and Gorlow in the same motion.
Why don't we just go ahead and do that right now while we do it? If there are other people, I'll ask you to add it as a personal amendment on the floor to add those names. So,
Oh, sorry.
Vice Chair Peters, are you okay with that? Let's redo.
Yeah.
Are you okay amending with those two individuals as well? And Assemblywoman Gorlow, would you second that with that as well?
Yes, I will. Thank you.
And since I know we have unanimous support here, all those in favor, please say aye. I
Aye.
ask you to unmute.
Aye.
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 Anyone opposed, say nay. Seeing none, that next motion passes unanimously. Again, I would assign that floor statement to Assemblywoman Tolles. If there are other individuals that do want to be added, I would ask you to contact Assemblywoman Tolles, and she could do a personal amendment on the floor to add those names in. And with that, I will end our work session, and we will move into our one bill presentation. At this time, I will open the hearing on Assembly Bill 351. This bill establishes provisions governing the prescribing, dispensing, and administering of medication designed to end the life of a patient. We have Assemblyman Flores with us to present Assembly Bill 351. I believe he has several co-presenters on the Zoom, and we do have several people in opposition to testify also on the Zoom. And at this time, I will turn it over to Assemblyman Flores to begin when you are ready.
Thank you, Madam Chair, Madam Vice Chair, and esteemed colleagues of the committee. I am Assemblyman Edgar Flores, for the record, representing Assembly District 28. And I am here today to engage in what I hope to be a very thoughtful dialogue, and at the same time, what I recognize to be a difficult dialogue in presenting Assembly Bill 351. I'd like to first give some context of how I landed in what I believe is a responsibility to move forward and push for this legislation. And then afterwards, I'll walk you through the bill. I'd like to note that you'll see that there are two amendments posted on Nellis. There is a mock-up, and then there is a second amendment by Washoe County. Both of those are friendly amendments. But for the sake of not jumping back and forth between documents, I'm going to focus on the original document as introduced. I will reference page numbers to that. And then after, when I hand over the presentation to our co-presenters, I will let them quickly go through the amendments to explain where they, why we have them and what their objective is. Just so you know, as co-presenters, I'm going to be having Kim Callanan, the CEO of Compassion and Choices Action Network, along with Peg Sandine, the Executive Director of Death and Dignity National Center, And then we'll also have 2 doctors who will be on the line available to ask any additional questions. As I get into the genesis of why I am here today and feel I have this responsibility, I do share that I am incredibly grateful for the work of David Parks, who on 3 separate occasions has come forth on behalf of many Nevadans to be a voice for them in presenting similar like measures in the past. And I am grateful for that work. And I am hoping to be able to continue the work that he has laid down for Nevadans, and that we can deliver this for Nevadans. And I do it in respect and honor to his work. If I can be honest, I don't think I would have engaged in this conversation years back. And maybe it's because I grew up in a traditional Latino Catholic household, where I think we talk about death, but death was always within the confines of very specific parameters that we were allowed to have the conversation. Or maybe it's just because my age had not allowed for me to experience enough of what death means in my family, how it impacts those around us. And as I get older, I am more and more constantly reminded of my own mortality, but more importantly, reminded of how limited the time is with those around me, those who I love and care about. If I can share a personal story, I think in coming forth with this particular bill, I think what really sent it home for me was with a particular family member who I remember when he was diagnosed with his terminal illness. It was obviously very devastating and incredibly difficult, but more importantly, he fought every second. And excuse me. Excuse me. And he fought every second of it. And I, in a very selfish way, I think I applauded it. And I think the reason I did was because for a long time, to me, death, I've always associated it to how it relates to me. And I think I realized that I needed to really go on the other side of that conversation. And that's where it hit me, that it's not about me. It's not about you. It's not about the family member. It's not about how everybody in that room feels, but rather that individual who suffered every second, and that we selfishly sit there and applaud because we saw it as an act of valor to say, you're doing that for us, but what about your pain? And I think that delivered it home for me and said, understood. I have a responsibility. Now, even if this bill would have existed or not, that person could have very well made that exact choice. Because this doesn't force anybody to do anything, but it gives them the power to, at that very painful reality, to say whether or not you have a choice on whether you're going to continue suffering, on whether you can endure another second of your terminal illness. And so I am here. I think the pandemic also put into perspective so much for me. And I realized that we just have a responsibility to engage in very difficult combos. And, in respect and honor of them, I said, all right, let's do it. And so I present this now. Now, I want to give everybody some context. If I could speak a little bit more broadly as to specifically the bill, because I needed you to see me getting to why I wanted to engage. And now that we have an understanding there, I'd like to just speak broadly as to the actual language and what we're doing. I've had an opportunity to speak to numerous Nevadans in every corner of Nevada. And I am so eternally grateful to those wonderful combos I've had with so many folk reaching out in such painful stages of their life that they may find themselves in, or their families, to speak up and say, we need to have this very real conversation about what it means to have a bill like this. And, some of these folk are incredibly healthy Nevadans. And they've, in essence, have broken it down to me and just said, look, we just want to know that if we're ever diagnosed with a terminal illness, and that after exploring every single traditional option, that they know that a legal, safe, and peaceful option is available to them to take control of the end of their life, and that they do it on their own terms. This goes to the very core of our individual rights to be able to say and to say, I no longer wish to suffer anymore. Now, I don't want this conversation to be allowed that it be taken to a lane that it's not, hijacked into something that's not real. This is not a question about choosing between living and dying. This bill is about having control and a choice at the moment of dying. Simply put, this legislation allows a terminally ill, mentally capable adult who is a resident of Nevada with a prognosis of 6 months or less to live, to have the option to request, obtain, and take medications should they choose to die peacefully in their sleep if their suffering becomes unbearable. And this isn't something new. This bill is modeled after the Oregon Death with Dignity Act, and that's been in practice for more than 20 years. And we haven't had a single instance of abuse or coercion in that state. And like I mentioned, it's been more than 22 years since the bill was enacted in Oregon. And now collectively, we have more than 40 years of evidence and cumulative data with medical aid in dying in Oregon and 9 other authorized jurisdictions. 1 in every 5 Americans, about 22%, now have access to this compassionate end of life care option. And the reason for that is because we have 9 states that have authorized something similar: California, Colorado, Hawaii, Maine, Montana, New Jersey, Oregon, Vermont, Washington, and Washington, D.C. And that's how we got the 22%. In addition to that, we also have New Mexico that passed legislation in March. And the governor is now scheduled to sign a bill tomorrow, April 8th, to enact it into law. We cannot forget that only the dying person can determine how much pain and suffering is too much. This law puts the decision in the hand of the dying person, in consultation with their doctor and their loved ones, or it should be for such a deeply personal healthcare decision, right? This is them deciding that they should have the opportunity to talk with everybody and get all the medical professionals involved and speak with all the families, make their peace with whomever. But at the very end, they should have the choice. If I could walk you through the bill, and again, I recognize that it's a very voluminous bill. So rather than walk you through the entire bill line by line, which would take up likely hours, what I'm going to do is reference sections and then walk you through the page numbers that those sections fall in. And then afterwards, I'll hand over the presentation. So first, on page 5, we have a new chapter, a new section that's being created. That's chapter 440. And you'll see in there section 1. And section 1 talks about and specifies that a coroner or coroner's deputy or local health officer is not required to certify the cause of death resulting from the self-administration of medication that is designed to end the life of a patient pursuant to this bill. Section 2, which falls between pages 5 and 6, requires that a death certificate to list the terminal condition of the patient as a cause of death of the patient and must not mention that the patient self-administered such medication. Section 3, page 6, prohibits a coroner, coroner's deputy, or local health officer from investigating such a death under certain circumstances and specifies the cause of death is not required to be certified. Section 4 through 30, which falls on pages 6 through 18, you'll see a whole host of different definitions. I will not walk by each definition, but I just want you to know where you can find them. Specifically, you'll hear in section 6, the definition of attending physician, section 7, competent, section 8, consulting physician, section 9, division, section 10, health and healthcare facility, section 11, person professionally qualified in the field of psychiatric mental health, and then section 12 defines terminal condition. I do think it is prudent that you go back and check those sections, that those terms will be used and referenced throughout the continuation of this presentation of the bill. Specifically, and it gets to the very core of this bill, section 13 in page 7 talks about the requirements in order to authorize a patient to request that his or her physician prescribe such a medication if the patient, number 1, is at least 18 years of age, number 2, has been diagnosed with a terminal condition by at least 2 physicians, number 3, is a Nevada resident, number 4, has made an informed and voluntary decision to end his or her own life, number 5, is competent, and number 6 is requesting the medication and is not doing it because of coercion or undue influence. It is incredibly important to make sure that these are the parameters. And again, that we remind everybody that nobody is obligated to do anything. In fact, you'll hear our co-presenters talk about how many folk, while in this situation, have decided to utilize this option, and you'll realize that it's not as much as you think. Next, in section 14, which is pages 7 and 8, it requires that a patient to fulfill certain requirements to request such a medication, including the patient must make 2 verbal requests and 1 written request for the medication, and that the written request for the medication must be signed by a witness. Section 15, which falls on pages 8 and 9, prescribes the form a patient must complete and request such a medication. Section 16, which falls on pages 9 and 10, imposes certain requirements before a physician is allowed to prescribe such a medication, including that the physician, 1, inform the patient of his or her right to revoke a request for medication at any time, 2, determine and verify that the patient meets the requirements for making such a request, 3, discuss certain relevant factors with the patient, including the diagnosis and prognosis of the patient and alternative options for care, 4, refer the patient to a consulting physician who can confirm the diagnosis, prognosis, and competence of the patient, and that the patient has not been coerced or unduly influenced, and 5, instruct the patient against self-administering the medication in public. In the 2 exhibits that you see that are friendly, again, the one particularly named mock-up, you'll see an amendment to section 16. Again, I'll hit that with our co-presenter just to explain what we're adding to it. We're not removing anything, simply adding something else to that list, and we'll explain why. Section 17, which is on page 10, requires a physician to refer a patient to a qualified mental health professional and to receive confirmation about the patient's competence if the physician determines that a patient who has requested a prescription for such a medication may not be competent. This is important because all of this goes to the heart of the conversation that I've had an opportunity to have with some of you, and that I've heard a lot of concern about, which is, how do we ensure that an individual in fact understands what they are doing? And I agree with you 100% wholeheartedly. All those other states who have engaged in this agree with you wholeheartedly. The 22 plus years of working in this area by many medical physicians will tell you that obviously that's very important to them. And that's why we've built in these safeguards in place to ensure that folk understand exactly what they're doing. Section 18 through 19, which is on page 11, prescribes certain procedures for the issuance of a prescription for such a medication and provides that only an attending physician or pharmacist may dispense such a medication. Section 19 prohibits an attending physician from prescribing such a medication based solely on the age or disability of the patient. Section 20, which falls on page 11 and 12, requires certain healthcare providers to include certain information concerning requests and prescriptions for and the dispensing of such a medication in the patient's medical record, requires that the physician or healthcare facility that previously provided care to a patient to transfer the patient's medical records to a new physician or healthcare facility. Section 21 allows the patient to revoke a request for such a medication at any time. So again, if you requested and later change your mind, that's perfectly okay and allowable. Section 22, which falls on page 12, provides that only the patient to whom such a medication is prescribed may administer the medication. You will see on this particular section, again, that there is an amendment, and we'll allow for our co-presenters to briefly touch upon that. Pages 12 through 13 address section 23, which prescribes certain information that must be reported to DBPEH relating to the patient who has been prescribed or self-administered such a medication, makes such information confidential with certain exceptions, and requires Division of Public Behavioral Health to complete an annual review of a sample of the reports. Section 24 requires DPBH to compile an annual report concerning the implementation of the bill. Section 25, that falls on pages 13 and 14, provides that the death resulting from a patient self-administering such a medication in accordance with this bill does not constitute suicide or homicide. This goes to ensure that it is noted that it is the underlying illness that is the cause of death. Section 26, which falls on page page 14, prohibits a person from preventing a patient from making or revoking or requiring a patient to make or revoke a request for a medication that is designed to end the life of the patient as a condition of receiving health care. Section 27, which falls on page 14, makes it a Category A felony to engage in certain fraudulent or coercive acts intended to cause a person to self-administer such a medication. Section 28, which falls on pages 14 and 15, clarifies that a physician is not required to prescribe such a medication, but that the physician must provide information concerning the prescription and self-administration of such a medication or refer the patient to another healthcare provider. Provides that a pharmacist is not required to fill a prescription for or dispense such a medication. Pages 15 and 16 address Section 29, which allows the owner or operator of a healthcare facility to prohibit an employee or independent contractor of a healthcare facility or any person who provides service on the premises of the healthcare facility from providing any services relating to prescribing a medication that is designed to end the life of a patient while acting within the scope of his or her employment or contract with the facility or while on the premises of the facility. Section 30, and if I could make just a little bit of point of clarification here. Section 29 is important too because it is important to make it abundantly clear that no healthcare facility has to engage in any particular conversation that we're engaging in this bill. So if there is a healthcare facility that wishes not to engage, that is something that can occur. And I just wanted to make that abundantly clear because I know that there was a lot of concerns and questions around that particular question. Section 30, which is on pages 16 and 18, prohibits a healthcare facility provider or healthcare or professionals association from taking certain actions against an employee, independent contractor, or member who provides accurate information concerning end-of-life care to a patient within or outside the scope of employment, contract, or membership as applicable. Or 2, facilitates the prescription or self-administration of medication that is designed to end the life of the patient outside of the scope of employment, contract, or membership as applicable. Section 30 is also particularly important because there has been a wide concern nationwide as to how accurate the information that's being disseminated in some of these facilities is. And it's imperative that we recognize that we are giving clear and accurate information, and that's what this section seeks to address. Section 31 addresses NRS 453.256, specifically to prescriptions. You'll find that on page 18, and it makes conforming changes by including the dispensing of a medication that is designed to end the life of a patient in the definition of medical treatment. Section 32, which is pages 18 through 20, addresses NRS 453.375, which is the authority to possess and administer controlled substances. And Section 32 makes conforming changes by excluding a patient requesting such a medication from the list of persons who may possess and administer a controlled substance. Section 33, pages 20 through 23, addresses NRS 454.213, which is the authority to possess and administer a dangerous drug. And it makes conforming changes by excluding a patient requesting such a medication from the list of persons who may possess and administer a dangerous drug. Section 34, which falls on page 23, addresses NRS 454.215, and it's the authority to dispense dangerous drugs. Makes conforming changes by excluding a patient requesting such a medication from the list of persons who may possess and dispense a dangerous drug. Section 35, which falls on pages 23 and 24, addresses NRS 133.065, which talks about conditional device and appointment. Section 35 prohibits a person from preventing a patient from making or revoking or requiring a patient to making or revoke a request for a medication that is designed to end the life of the patient as a condition in agreement, contract, or will. Section 36, which falls on page 24, addresses NRS 159.054. And what this does is it provides that a proposed protected person, should not be deemed to be in need of a general or special guardian solely because the proposed protected person requested a medication that is designed to end his or her life or revoke such a request. Section 37, which is pages 24 through 27, address NRS 239.010 and addresses confidential information in public books and records. It makes conforming changes to ensure certain information is confidential. Section 38, pages 27 through 28, addresses NRS 598.0923, deceptive trade practices. And it makes Section 38 makes it a deceptive trade practice for a healthcare provider. Lost my place here. Section 38 makes it a deceptive trade practice for a healthcare provider or an owner, officer, employer, independent contractor of a healthcare facility to knowingly engage in any false, misleading, or deceptive conduct concerning the willingness of the provider of healthcare facility to make certain action relating to the prescription and self-administration of such a medication. Section 39, which is pages 28 through 29, addresses NRS 639.1375, advanced practice registered nurses. And it clarifies that an advanced practice registered nurse is not authorized to prescribe a medication that is designed to end the life of a patient. Section 40, which falls on pages 29 through 30, addresses NRS 639.2351, the advanced practice of registered nurses. And it makes conforming changes to clarify that an advanced practice registered nurse is not authorized to prescribe a medication that is designed to end the life of a patient. Section 41, which is pages 30 through 31, addresses NRS 639.238, which is in regards to prescriptions, not public records. And it makes conforming changes to ensure certain information is confidential. Section 42, pages 31 through 32, addresses Chapter 688, and Chapter 688A and 688B. These are both new sections. And what they do is they prohibit insurers from, number one, refusing to sell, provide, or issue a policy of life insurance or group life insurance or annuity contract, or charging a higher rate because a person makes or revokes a request for a medication that is designed to end the life of the person or self-administers such a medication. Or two, conditioning life insurance benefits, group life insurance benefits, or the payment of claims on whether the insured makes, fails to make, or revokes a request for a medication that is designed to end the life of the insured or the self-administered, such as medication. Section 44, which is pages 32 through 33, addresses NRS 688B.040, provisions required in a group contract, makes confirming changes reflecting the prohibitions in sections 42 and 43 on the policy of the group life insurance. Section 45 on page 33 requires DPPH, DHHS to make the prescribing forms in the bill available not later than 45 days after the effective date of the bill. And lastly, Section 46, page 33 specifies that this bill becomes effective upon passage and approval. Members, I apologize for having to go so deeply into the sections. That's the fastest way I could think of going through the bill. I appreciate you indulging me through my slight moment of vulnerability there. I did not intend for that to occur, and I apologize for that. I will now hand over, with the committee's respect, the presentation over to Kim Callanan, who is the CEO of Compassion and Choices Action Network. Thank you, Madam Chair.
Thank you. And if I could just remind our speakers, please state your name for the record before you speak each and every time. I know it's very awkward. And Assemblyman Flores, please don't ever apologize for being human and having compassion.
My name is Kim Callanan, and I am the President and CEO of the Compassion and Choices Action Network. Thank you so much for having me here today, and thank you to Assemblyman Flores for sponsoring this bill and for his very authentic and courageous remarks. And good afternoon, Madam Chair and members of the Health and Human Services Committee. What I thought I would do was first start off and just re-encapsulate some of the key components of the bill, since Assemblyman Flores did go through 33 pages, and there really is a tremendous amount in this bill. As he noted, the legislation is modeled after the Oregon Death with Dignity Act. We have more than 20 years of experience in Oregon, and we have a combined 60 years of experience across the other 9 states that and Washington, D.C. that are authorized. This bill includes the same strict eligibility criteria and core safeguards that are in all of the other bills that have been proven to find that balance between ensuring that vulnerable populations are protected, but also making sure that this compassionate option is available to those who want it. It is entirely optional for everybody, for the doctor, for the patient, for the healthcare facility. Nobody is forced to participate. And the availability of the option brings people comfort during a very difficult time. As Assemblyman Flores noted, this is for a really small group of people. A person has to be an adult, mentally capable, terminally ill, have a prognosis of 6 months or less to live, and that's very important. It's tied to the prognosis in hospice, so that people aren't choosing between death and care. They do have hospice care available to them if this is an option that they don't want to afford themselves. And one of the very key criteria is that the person must be able to self-ingest the medication, so that they are always maintaining decision-making authority and are capable and able to change their minds at any point. One of the amendments that Assemblymember Flores mentioned is an amendment that will strengthen the language that's being used around self-administration to make it very clear that only the qualified patient is able to self-administer the medication and that it can only go through ingestible means. So that is one of the amendments, and it will allow your bill to align more directly with the other authorized states, and is a very important safety feature. The law also has more than 24 additional regulatory requirements. So when you look at that 33-page bill, there are a lot of steps that a patient has to go through. 2 doctors have to certify that the person meets the requirements. The person makes 3 separate requests, 2 oral and 1 written. There are 2 witnesses that have to confirm that the person is making this request voluntarily. There's a 15-day waiting period. And there's mandatory reporting by doctors. All of the provisions in this bill are also on top of all of the other regulations that govern the practice of medicine. So one of the things that's important with this legislation is you want to have enough safeguards in play that it ensures that vulnerable populations are protected, but you also want to be sure you're giving your medical providers the ability to actually support their patients. And so you're really striking a fine line. And this legislation really does help ensure that a small number of people will be able to access it. The other thing that it includes is a requirement for a lot of education of the patient before they afford themselves of this option. The attending physician must discuss with the patient the importance of having another person present when the patient self-administers the medication, and they must review the benefits of notifying the patient's next of kin of his or her decision to request a prescription for medication that is designed to end the patient's life. One of the additional proposed amendments that is there for your consideration, which we are in support of, is that the doctor should also counsel the patients about the benefits of discussing their decision to request the medication with their religious, faith, spiritual, or support leader. So that's another provision that is being recommended, and this would be the only bill in the nation that includes that provision. But it is, I think, a good addition to the legislation. As I mentioned, on top of all of the provisions of this bill, you also have the practice of medicine that governs this and the standard of care that's been developed. And it's worth me noting that your own Assembly Member David Ornlicker, Dr. David Ornlicker, I could say, is one of actually the lead author for a peer-reviewed Journal of Medicine article that was published in 2016, which outlines the clinical criteria around medical aid in dying. Assemblymember Flores spoke about how you'll be surprised that very few people choose to use the law. And this is really important. Across all of the authorized jurisdictions, across all 60 years or 50 years of data, there have only been about 4,300 people who have chosen to use the law. It's a really, really small number. So the concern that large numbers of people are going to use this law that's not the reality in practice. It hasn't been in any of the authorized states. It's far fewer than 1% of people. So then, of course, the question becomes, if so few people are choosing to use the law, then why spend all of this time authorizing this as an option? And it's because it's not just about the small number of people that choose to use the law. It's about all the people who get the peace of mind of knowing that should their suffering become too great, that they have an option. In addition to that, what we know is that when the law gets implemented, what the evidence and the data shows is, and there was a Journal of Medical Ethics report that showed this, is that there's no concern about abuse or coercion or misuse. What the Journal of Medical Ethics report concluded was that assisted dying did not pose any heightened risk for any population, including vulnerable populations such as the elderly, the uninsured, and those who are physically disabled. What this law does is it provides profound peace of mind to those who choose the law. And a third of the people who get the prescription will never even take it, but they get profound peace of mind simply knowing that the medication is there and that they have the option should they need it. Research from a Journal of Palliative Medicine article demonstrated that medical aid in dying also improves end-of-life care generally by contributing to more candid conversations between doctors and patients, higher hospice usage rates, and improved palliative care training for physicians. Because we now have so much evidence and data, we also are seeing this movement grow across the country. So as Assemblymember Flores mentioned, just tomorrow, the governor of New Mexico is planning on signing the legislation to make that the 10th state, 11th jurisdiction to authorize medical aid in dying. But what's key is that 7 of those jurisdictions have taken place in the last 6 years. Polling data, which was just completed in your state last month, shows that Nevada voters want this compassionate option. 3 out of 4 residents support passage of medical aid in dying, including widespread support across all demographic groups. And we've seen that over the past 6 years, 30 national and state medical professional associations have endorsed or dropped their opposition to medical aid in dying in support to the growing reality that this is something that the American public wants. Within the state of Nevada, the State Medical Association has taken a neutral position on medical aid in dying. We no longer have to hypothesize about what's going to happen when this law gets implemented. The evidence is very clear. Medical aid in dying protects vulnerable populations. It affords dying people the autonomy and compassion during the most difficult time. It improves end-of-life care generally by resulting in more conversations about hospice care and improved palliative care training, and it costs almost nothing to implement. The cost of inaction, however, is truly immense. Without the option of medical aid in dying, terminally ill individuals may not try that one last miracle treatment, because often it is the treatment itself that causes the most amount of suffering, and they're afraid to try that one last treatment without knowing that they have this option available. They may also choose violent means to end their suffering, and they could experience needless agony when they die, while families and doctors remain powerless with no legal way to respond to their pleas for help. Terminally ill residents do not have the luxury of endless deliberations. They need the relief that this law affords them right now. Not a single additional person will die if you authorize medical aid in dying, but far fewer will suffer. On behalf of our thousands of supporters across the state, supporters like Hannah Olivas, who need this option right now, I urge you to let the evidence, the data, the strong public support for this end-of-life care option guide your policymaking and pass this bill this session. Thank you so much for your consideration.
Thank you. Assemblymember Flores, for the record. Madam Chair, if I may ask that we allow our Executive Director from Death and Dignity National Center, Ms. Sandine, to do a brief presentation now?
No, that's fine. Go ahead.
Thank you.
Peg Sandine, Death with Dignity National Center in Portland, Oregon. And Chair Nguyen and Assemblymember Flores and all committee members, thank you for agreeing to listen to my presentation today. I'm a social worker. I live in Portland, Oregon, and I have been working on Death with Dignity for 16 years. And I'm really pleased to be able to share my experience with you. And as a social worker who has built a career caring for and working with people who are dying, I just want to reflect on the vulnerability and the honesty with which Assemblymember Flores shared the story with us today. I hear stories like this every day about people who are dying, people who would qualify for Oregon's Death with Dignity Act or people who don't. And I think that one of the things that it's important to remember is we all get one death, and we all deserve an option like Death with Dignity. One of the most difficult things for a terminally ill individual is the silence, right? The silence surrounding the dying experience. And this silence arises out of society's unwillingness to face death directly. And I know that at least one family in the state of Nevada tonight will have a difficult conversation about dying and last wishes and advance directives because they were somehow engaged with or heard about this hearing today. And that is meaningful. And what's also meaningful is the care with which this bill before you has been constructed. We have 10 other jurisdictions with death with dignity bills. And so what I know is that this bill in front of you represents the best of all of those pieces of legislation. It provides strong, time-proven safeguards which have been well covered by Assemblymember Flores. These safeguards protect vulnerable individuals from coercion, and at the same time, these safeguards do not act as barriers to access for those who need it. And this bill strikes a tension between protection and access, and this tension is difficult to strike, and our team in Nevada has worked with all the necessary stakeholders to get this bill just right. The proposed law that you are considering today is at its core a medical standard of care. So when you go through section by section, you can see what a physician has to do in order to prescribe medication to a patient who requests a hastened death. By enacting this law, the Nevada Legislature will send a strong message that a compassionate response to suffering is available in the state through medical aid in dying, but that healthcare providers must follow the carefully regulated safeguards you are considering today. AB 351 puts decisions about easing suffering in the hands of terminally ill patients, allowing them to engage their family members, their physicians, clergy members, and anyone else they choose, if they so choose. It sets aside outdated and archaic government bans on a medical practice that is currently legal for 72 million Americans, a practice that is validated, researched, effective, and full of safeguards to protect vulnerable populations. Nevada has considered similar legislation in the past, and those of you who have engaged in this debate in prior sessions, you know that you're going to hear a lot of negative accusations about this bill. For more than 2 decades now, we have heard these same slippery slope arguments. Statement that this law will target individuals who are poor or who are living with disabilities, the elderly. Statements suggesting that those without medical care or access to healthcare resources will be forced to end their lives using medical aid in dying because it is cheaper than treating cancer. These slippery slope arguments are just not true. Independent researchers have concluded that the results are quite the opposite. One group of researchers explored data out of Oregon to determine if there was a disproportionate impact on 10 groups of potentially vulnerable patients. And the data led the researchers to conclude, and I quote, "There's no current factual support for so-called slippery slope concerns about the risks of legalization of assisted dying. These patients are not at risk." I have already read letters to the editor in Nevada published suggesting that death with dignity will undermine hospice and palliative care services. And the researchers are clear on this point also. In a study published in the Journal of Palliative Medicine, research concluded, and again, I have another quote, "Another concern regarding the legalization of physician aid in dying is that physician aid in dying would become a substitute for quality end-of-life care. This study adds to the evidence that the choice to pursue physician aid in dying does not appear to be due to or a reflection of poor end-of-life care." What we do know is that for the states that have enacted death with dignity laws, the question is, or the point is that people have access to death with dignity and hospice care. It's not one or the other. The data demonstrate that they come together in all of the jurisdictions that have enacted death with dignity legislation. A lot of people want to speak against the Oregon experience, and you'll probably hear that today. But in almost every legislative hearing I've attended, these people are not from Oregon. And the thing is, I've worked in this state. I am an Oregonian, and I've worked with people who have used this law for almost 20 years. Oregon's law works as intended to give dying and suffering patients more options at the end of life. I very much appreciate Assemblymember Flores and all the work he and countless others from Nevada have contributed to bring this important bill to you today. And my organization, myself as a social worker, I stand ready to help Nevada enact and implement this critical piece of end-of-life care legislation should our support be necessary. Thank you.
Madam Chair, Assemblymember Flores, for the record, at this time we are open for questions.
Wonderful. Thank you, Assemblyman Flores. I'm looking around. I have a couple of questions here in the queue, and if you can, as members of the committee can send me a Skype if they have additional questions. At this time, I will start with Assemblyman Matthews.
Thank you, Chair Nguyen, and thank you, Assemblyman Flores, for the presentation. I know that it's been noted that this bill is modeled after Oregon's Death with Dignity Act. And I know also that the stated intent of this bill is to provide options for those who are suffering and those who are experiencing unbearable pain. The Oregon Health Authority's own data summary on that state's Death with Dignity Act notes that in most cases, current pain or even concern about future pain is not cited by patients as a reason for obtaining these drugs, but rather the number one reason listed by patients who die from assisted suicide is being a burden to family and friends and loss of enjoyment in usual activities. And so my question then would be, given the intent of this bill, what safeguards, if any, are in place in this bill to ensure that we don't see the same thing happen here in Nevada? Thank you so much.
So Kim Callanan with the Compassion and Choices Action Network. So first of all, it's really important to remember that that Oregon data is coming from a doctor filling out a form about their perception of why a patient is choosing to use the option. It's not the patient's self-reported reason for choosing the option. So that first is really important. Secondly, when you're talking to a patient that's at the end of life, it's not just about pain, but it's about all the pain and suffering that they are experiencing. And Assembly Flores, I think, spoke to it so beautifully in the beginning when he talked about his own personal experience, watching his loved one who is going through this. A person who's at the end of their life, they're going through a whole host of things. It's the totality of that experience that determines whether or not they're suffering too much, and really only the dying person can decide how much suffering is too much. So I don't see the Oregon data as a problem. It's a very small number of people who choose the option, but they're getting peace of mind and knowing that they don't have to suffer from whatever their definition of suffering is. And again, they're terminally ill, they're already going to die. The question is simply how they die, not if they're going to die.
Okay, thank you. Thank you, Madam Chair.
You're welcome. Do you have any follow-up, Assemblyman Matthews?
No, not at this time. Thank you.
Thank you. Next, if we can go to Assemblywoman Thomas.
Thank you. That was difficult to unmute myself. Thank you, Chair, and thank you, Assemblymember Flores, for bringing this really compassionate bill forward, AB 351. My question actually has to do with our Black, brown, and people of color who at times have had a disparaging experience with healthcare personnel, and the crux of my question is there any data showing that people that are in the minority have experienced a reception of the same outcome as with dignity when they've decided that life is enough for them? Meaning, are they disparaged when it comes to accepting this as a final episode in their life's journey.
Assemblymember Thomas, Kim Callanan with the Compassion and Choices Action Network, and Assemblymember Thomas, thank you for that really thoughtful question. We share your commitment to health equity at Life's End, and actually have an initiative going with our African American and Latino leadership councils to try to address the systemic inequities that exist in end-of-life care broadly, because they are pretty profound, and it's across the entire end-of-life care spectrum: hospice, palliative care, pain management. Unfortunately, Black and Brown Americans do not have, the same level of, are more likely to have, less likely to enroll in hospice care and get adequate pain management and all of those things that you're referencing. And so that is a huge commitment and priority for the organization. In terms of this particular bill, what ends up existing, and if you look across at the data, is that very few minorities take advantage of the option. And so one of the things that's positive and good about the initiative is that everything is self-directed. The person has to make the request. They're in charge of the process from start to finish. So they're really, with this particular end-of-life option, there's not a chance that a person is going to be coerced into using the option, because it is entirely self-directed. But what we do see, and it's an issue that we will address across the entire end-of-life care spectrum, is that a lot of public education is needed in order to ensure that African Americans, Latinos, other minority populations are aware of and taking advantage of all end-of-life care options that are available to them, so they're able to make the best decisions that they can for themselves, that's their values and priorities. The bill actually has the potential to help ignite that, because as Peg referenced in her opening remarks, what we see happen is this legislation opens the door up to people finally having a conversation that they otherwise avoid. And it might open up because there's a bill hearing. It might open up because they see a media article. It might open up because now they ask their doctor. And that's why you see increased enrollment into hospice care after the legislation gets implemented into a state. A patient goes in and they say, I want to be in control of my end. It opens up the door for that conversation. And then you have doctors and patients finally having a conversation about what kind of end-of-life care options you have. And it ends up improving end-of-life care across the board. So we are, as an organization, very committed to addressing the inequities that exist across all of end-of-life care. This bill, it does work to ensure that nobody will be pushed into this as an option in its current form.
Thank you. I appreciate that answer. Thank you, Chair.
Thank you. Next we can go to Assemblywoman Titus.
Thank you, Madam Chair. I appreciate the opportunity to ask some questions, if I might. And Assemblyman Flores, thank you for bringing this bill, and thank you for sharing your personal story. And you should never apologize for being human and have an emotion. And I'm honored to have to actually hear your story today. So thank you for that. I have some questions actually about the bill. These are emotional issues. As a physician, literally involved, literally with hundreds of patients at the time of their death, understanding their fears and concerns, and had patients ask me, please, doc, don't let me suffer. I'm worried about pain, et cetera. And that's always my question to them. What are you afraid of? And I was there for them. I'm actively involved in making sure we have palliative care, making sure we have hospice care. So that concern about the number one, death with dignity, and not making sure they don't suffer, usually I can absolutely solve that for them. And so making sure that doesn't happen. So, but never actively engaged in ending their life. But I have questions about the bill itself. So if I might do that, Assemblyman Flores, and focus on the bill. The rest is all about, I know a lot of emotional folks on both sides of the story, but I have some concerns, which is why one of several reasons in the past this bill has not made it past is because of some of these true concerns that I see. First and foremost, the testimony happened early that there was no abuse of this that in Oregon. However, my concerns with this on the bill in section 1, it is forbidden for a coroner to investigate the case. So however would we know if the case was abused or not when somebody who has the prescription they forbid the coroner to investigate the case? So how do we know there isn't abuse when you can't investigate it?
So the intention of the language in section 1 is that if the person, Kim Callahan, Compassionate Choices Action Network, the intention of the language in section 1 is that if the person, has chosen this as an option, that there's nothing to investigate because you know that they're going to take the prescription medication. If there is some reason or suspicion of foul play, of course the coroner would be able to investigate. It's not stopping an investigation if there's foul play, but if a person has chosen this as an option and has gone through the process, there's not a reason to investigate because the investigation is going to show that they've taken a prescription to end their suffering.
So again, I would disagree with that because just because they've gotten the prescription doesn't mean that they're ever going to use it. And you yourself has testified that many people apply for this and then don't use that. So how does that then, just the very fact that they've applied for the prescription, now negate any other studies or any other investigation, at least a walkthrough? So I'll have to disagree with you on your comment on that one. And then next on section 3 and 25, I as a doctor have signed, after a doctor of 36 years, signed many, many death certificates. In that death certificate, there are immediate cause of death and then associated cause of death, and there's up to 5 lines per se on underlying causes of death. In your bill, it mandates that we have to sign that it is from the cause of death which allowed them, or the diagnosis that allowed them to obtain this medication, the 6-month diagnosis. Now, we all know, and you have to know, that just because a doctor says you're going to die in 6 months, I've had patients die in a week, and I've had patients die many, many years later. So the diagnosis of 6 months doesn't mean that's inevitable. I believe there's a power greater than me, and just to say you're going to be dead in 6 months, frequently that doesn't happen. So my concern with that is that by not being able to sign that, yes, indeed, they did take an assisted suicide drug, and say they took it within a day of getting that suicide drug, their diagnosis of pancreatic cancer, which the average lifespan of somebody with pancreatic cancer, frankly, is 6 months. But now this person has died in 2 weeks, not from pancreatic cancer, but from taking this medication. That skews the data on when I have a discussion of what the average lifespan is on a person with X disease. And so, because we're looking at terminal diseases here. So not being allowed to say, yes, it was, they took this medication, but with the caveat with the terminal disease by saying they died from pancreatic cancer, which is absolutely not true. They died from the medication, because I would write down immediate cause of death, respiratory distress, heart attack. Why is that any different? Their underlying cause would still be pancreatic cancer, say they had that and associated. So it doesn't take away that they had that disease. Why the push for not giving the truth, the actual fact that they died from an overdose of medication?
So I know that Dr. Grube is on the line, and I figured it would be nice for Dr. Grube to respond to this one.
And can I remind everyone to please state your name for the record before you speak, just so our committee secretaries can keep accurate record.
I'm sorry, Kim Callahan, Compassionate Choices Action Network, tossing it over to Dr. David Grube.
Thank you very much. My name is David Grube. I'm a retired family physician here in Oregon who did respond to patient requests regarding aid in dying. And I really appreciate your question because I've heard this many times, and we've had many conversations with other physicians about this. From my perspective, and I think maybe the perspective of the bill, is that there are 2 reasons for the death certificate. One is to establish the legal parameters of the estate, and the other is the epidemiology of the disease that you kind of talked about. The latter will be covered by the reporting requirements that you'll have in Nevada that we have in Oregon. And so all that data will coming to the state for epidemiological concerns. The death certificate, however, is a public document, and as a public document discoverable by anybody. And when death with dignity or medical aid in dying, or the name of the bill, is on the death certificate, that has implications publicly for the family, for intimacy, for HIPAA violations, etc. So I think your concerns are addressed by the reporting requirements that your state of Nevada will be requiring.
Again, I respectfully disagree. However, Madam Chair, may I still continue a couple more questions? I have a couple more, if I might, please.
Yes, if you could get to the question, though.
Okay, get to the question. So section 28, I'm mandated to refer to another physician. Is there a timeline in the bill that says how much time do I have to refer that? And is there going to be a list published somewhere so that I, as a provider, have a list of the providers, other providers that are willing to do this? How does that work?
Kimberly Callanan with the Compassion and Choices Action Network. There isn't a time frame that's in the bill. It's expected that in the same way you would refer somebody in a timely manner to any other provider, that you would do the same with medical aid in dying. So it's just asking you to follow the normal practice of medicine and to refer the patient out. There's also the option of referring the person for information. So it doesn't mandate that it has to be to another provider that will practice medical aid in dying. It can also just be to a general information source so that the person is able to obtain information.
And somewhere there's a list somewhere of other providers. So the next question real quick, who pays for the medication? They're mandated, you get this prescription, they go to the pharmacist. Section 29 mandates that the pharmacist fills it. What's the average cost, and what if they can't pay? Does the pharmacy have to dispense the medication?
Kim Callanan with the Compassion and Choices Action Network. The medication can be, most of the time, a person is paying for the medication themselves, or some of the states that have authorized medical aid in dying have allowed for the medication to be paid for through their state Medicaid program, depending on the state, and then private insurance does often cover the medication. It runs about $550 to $600.
And there's no shortage of supply.
There are. Well, go ahead, David.
Yeah, Dr. David Grube in Oregon again. There's no shortage of supplies at the present time. The prescription is a compounded prescription of currently available medications.
Last question, Madam Chair. Section 4243 mandates insurance companies cannot deny somebody insurance coverage even though they have noted that they're going to take this medication. So for me, the person can get a terminal illness, say, well, I'm going to go immediately get this medication and then apply for life insurance. It seems from a business standpoint, you're putting the insurance companies at a huge burden there that they could sign up. There's no limit that they could sign up for this life insurance. It seems to me, how does that work in Oregon? They can still issue the life insurance policy, yet I know I have a terminal illness.
David Grube in Oregon, these people are about to die. There's not one single one of them would be available. Life insurance, could they ever be covered? As you know, in Oregon, 95% of them are already enrolled in hospice, and so they're covered in that way. But there's not any possibility that this group of people would be eligible for life insurance.
Why is that in it that you can't refuse life insurance? Section 43 says that specifically. You cannot deny life insurance. It says you cannot deny under a group policy, cancel a policy, or refuse to issue an insurance if you apply. That to me is they could go and apply once they get the diagnosis.
Yep, I do not believe that. This is David Grube again in Oregon. I do not believe we have that as part of our Death with Dignity Act in Oregon. Okay. So I defer to those people.
Yeah, Section 2, number 1, Section 42, number 1B. You can't refuse to sell, provide, or issue life insurance to somebody who applies for this.
Kim Callanan with the Compassion and Choices Action Network. So that was not the intention of it. It could have been that in bill drafting, something got got reworded. So that is certainly something that I am sure that we can look at with Assemblymember Flores. And if your conclusion is correct, we would be supportive of an amendment if he was.
All right, thank you all for your presentation. Thank you, Madam Chair, for your tolerance of my line of questioning, but I just felt they needed to be asked. So thank you very much, all of you.
And Assemblywoman Titus, if you have additional questions, please ask them. I would just try to avoid disagreeing and having arguments over the answers. We can disagree about things, but I would allow our presenters to present their information. Do you have any other further questions?
Madam Chair, I have a bunch more, but I'm good to go. I know other folks have questions. Thank you.
We'll see if we can come back around to you if they aren't answered by other members. Assemblywoman Krasner, you are up next.
Thank you, Chair Nguyen. First, I'd like to say thank you to Assemblyman Edgar Flores for his presentation and sharing his personal story with us. My question is for Kim, Ms. Callanan. So in preparing for this hearing today, I did a lot of reading. I read several articles on the topic. And I'm glad that she talked about vulnerable populations and protecting vulnerable populations. Because in some of the articles, I was reading about the limitations on the safeguards for vulnerable populations. And I'm just wondering, is there anywhere in the bill where there are safeguards to prevent an insurance company from delaying or denying expensive treatments for, say, cancer, and thus just sort of causing the person to suffer and sort of almost pushing or encouraging someone to choose end-of-life prescriptions. And this is something I saw in the National Council on Disability that just says basically when assisted suicide is legalized, it immediately becomes the cheapest treatment. Direct coercion is not necessary. If insurers deny or even simply delay approval of expensive life-sustaining treatment, patients can be steered toward hastening their death. If you could please comment on that, thank you.
Thank you, Assemblyman Krasner. Kim Callanan with the Compassion and Choices Action Network. So the decisions that an insurance company makes about whether or not to provide care have nothing to do with the medical aid and dying laws being in a state or not. Insurance companies have their own, they look to see whether or not a treatment meets their criteria, and that's what determines whether or not they do that. The bill does not allow for an insurance company to deny treatment and then offer medical aid and dying as an option. And if that was really happening, if that was, the way it worked across the state, you wouldn't have 4,500 people utilizing the law across a combined 50 years of experience. The law requires that the person be the one who's making the requests and asking for the option. And while I understand that that is a concern, the legislation really does address that concern.
No
Dr.
further
Grube,
questions.
Do you have any other questions? I'm sorry, Assemblywoman Krasner. No. I see, Dr. Grube, you've unmuted. Did you have a response to that as well or no?
Yes, thank you so much, David Grube in Oregon. That is a concern that I've heard brought up before, but it's not a reality. It's not something that the experience in Oregon doesn't show that has ever happened. And again, this group of people are near death, have been through all the kinds of treatments. It's not like they're being denied a last treatment. This is a group of hospice patients for the most part. So that is not really a thing that we've ever seen in happening in Oregon.
Thank you. And next we can go to Assemblywoman Gorlow.
Thank you, Chair. And thank you again, Assemblyman Flores, for bringing this forward. I have a couple of softball questions, then one that's a little bit more of substance. First, you'd mentioned that 43 people had chosen this. I apologize, I missed. Was that just in Oregon or is that a total number?
It's 43,000 people across all of the authorized states that collect data, which I think is about 9 states in the combined number of years, about 50 years.
Over 50 years, okay. And then in section 22, it says that the patient must be able to ingest the medication themselves. So is this a pill form or is this a liquid? Just curious.
Yeah, this is David Grube in Oregon, Dr. Grube. The current protocol is a liquid of about 4 ounces or half a glass of water that is drunk. Individual will fall asleep in about 10 minutes and die very peacefully in about well less than an hour. It can sometimes come as a powder that the family would mix with the liquid. So it could be powder or it could be a liquid form. It's not pills though.
Thank you so much. And then my last question goes to section 28, which states that a pharmacy does not have to dispense such medication. Has that been a barrier in other states?
This is David Grube again in Oregon, and I would like to address that personally because I actually had a woman who went 4 miles on her in her electric wheelchair. She was dying of breast cancer. She couldn't walk anymore to get a prescription. And I live in a small town, and the pharmacist that day did not believe in death with dignity and would not dispense the medication that was sitting on the shelf. And so she had to get right back in her Mobi and go all the way back to her residence and return another day. So this is a thing that can happen.
And,
Thank you.
Yeah.
Oh, go ahead. I'm sorry.
Callanan with the Compassionate Choices Action Network. If I can just add, David's absolutely right that this is something that can happen. The good news is that we do have more pharmacies that are participating, and with the ability to mail, we have been able to mitigate this as an issue. But it's absolutely a challenge that that you have to work through after the law gets implemented.
Thank you. And I apologize. You mentioned that can be mailed to a patient as well? Okay, great. Thank you so much.
Madam Chair, Assemblyman Edgar Flores, for the record, if I could go back to the question posed by Assemblywoman Titus, please.
No, go ahead. And I know that Carly O'Krent with LCB Legal can also assist. I know that she looked up some of the concerns too, but I will turn it over to you to answer any of the questions.
Thank you, Assemblywoman. Again, just for a point of clarification, Assemblyman Edgar Flores, for the record, Assemblywoman Titus, thank you for your question. And we had a folk we were messaging back and forth just for a point of clarification, and grateful to legal and the folk who helped draft this bill, particularly to section 42, page 31, lines 42 to 45. You posed a question as to if we were somehow tying the hands of an insurance provider now by including that section. And we just wanted to clarify that the insurance company now can still refuse based on somebody having a terminal disease or illness. They can still do that. What this section is clarifying is that they cannot solely say we're not going to based on the fact that the medication's been requested. So we just wanted, we wanted to very specifically delineate that so that we're not sending mixed messaging. But the insurance company, as they do now, would be allowed to refuse based on the fact that they're, somebody has a terminal illness. That doesn't change. This is just specifically denying on the basis of the actual request for the medication.
Thank you, if I might, thank you, Assemblyman Flores, for that clarification. And again, I'll follow up offline with, because I still have some concerns about that provision being in there and maybe the only thing they know about the patient. So anyway, thank you for that clarity.
Thank you.
I would encourage you, Assemblywoman Titus, to reach out to Ms. O'Krent. I know that she provided a similar answer, and she said that Assemblyman Flores kind of stated what she would have said. But if you have further clarifying questions, I would ask you to reach out to her. And next, I will go to Assemblyman Hafen.
Thank you, Madam Chair. And I want to start by thanking Assemblyman Flores for bringing this bill forward. It has made me do some soul searching and actually made me do some research in the Bible, because this is a very tough conversation for us to be having today. And I appreciate the Assemblyman for taking it on and bringing it forward. My question to the experts is that in some of the research, not necessarily in the Bible, but in the other states that have had the assisted suicide path, we've seen a direct correlation with increased suicides. And my concern is that with the recent pandemic and lockdown, we've seen a dramatic increase in suicide attempts. And I was just wondering if there was an explanation of why we're seeing a direct correlation with the states that have passed the assisted suicide, specifically Oregon, and the increase in suicide.
This is David Grube in Oregon, and I might respond to that, the very important question. I actually will send you an article that recognizes there is no correlation between increased suicides in Oregon and our Death with Dignity Act. It's probably more based on the fact that our population has increased and other situations and stressors in life. Suicide in America is a huge problem that we in medicine and in all parts of our society need to address genuinely. And that's a very important thing that we do. However, it is not true that there is a direct correlation between the passage of Death with Dignity Act in Oregon and suicides in our state. So I'll send that data and a study that has been done to show that there is no correlation.
I think we also have Ms. Sandine who wanted to respond as well.
Yeah, Peg Sandine for Death with Dignity National Center, and I would echo just what Dr. Grube said. Very much there is not a direct correlation, and there's statistical evidence that there's not a direct correlation between suicide and the enactment of the Oregon Death with Dignity Act. And suicide patterns are just different across the United States. Some states have higher levels, some states have lower levels, but it's not related to the existence of any of the Death with Dignity Acts.
I believe you have some other follow-up questions, Assemblyman Haven. Go ahead.
Well, I have a follow-up, thank you. And I would appreciate to look at that data because the data that I've looked at is showing that Oregon's suicide rate is 41% higher than the national average. And if I understand, the problem is not the assisted suicide, but the increase in population. I'm just confused why an increase in population would be the rationale for a percentage increase. I could see the number increase, but not a percentage increase over the national average being caused by population. So if you could just clarify that for me, thank you.
Yes, thank you very much. This is David Grube in Oregon. Thank you very much to clarify that. I didn't mean that it was an increase in the percentage. That's a part of the argument that shows there's no correlation. And I will send you that study so that you could read that. But you're correct.
Thank you. And thank you, Madam Chair. I have no further questions.
I actually have a follow-up question to that. When you're looking at like some of these studies, because I'm sure, like myself, many of our committee members have been inundated with emails in support and opposition of Assembly Bill 351, and that reference to like high suicide rates in Oregon over the past, I don't know, since 1999, I think is what most of the emails and like other like types of correspondence I've received kind of indicate. Do we have any indication of what the suicide rates were in Oregon prior to this? Is it just too hard to like make any kind of like specific correlation between their law and those rates without taking into consideration other factors like COVID or other forms of isolation or weather or any of those things?
Kim Callanan with the Compassion and Choices Action Network. When you look at the studies that are looking at suicide rates, there really just is no correlation. There's so many different factors, as you noted, of things that could lead to suicide. The thing that actually shows there is that the Western states that have laxer gun laws are the ones that have higher suicide rates. That's where the correlation exists. If you look then at the states that have enacted medical aid and dying laws that are on the East Coast, where there are lower suicide rates there. So there's really just, there's just no correlation. There's no causation. They're really just very independent.
At this time, I'm looking around to see if there are any other people here with questions. Assemblywoman Titus, would you like me to go back to you for some additional questions before we go to support testimony?
Thank you. I appreciate it. And I do appreciate the opportunity. Question on Nevada resident. Nevada is famous in history that we became a lot of people became Nevada residents because of our divorce laws many years ago, as other states had long time to get that divorce. We have numerous places in both southern Nevada, northern and southern Nevada that were established because of they could get a divorce here. So how does this affect when we say Nevada resident? There's no limitation that you have to be here 6 months. What's the definition? I guess our legal will have to answer this. What's the definition of Nevada resident? Can they be here just a week and they're considered a Nevada resident?
Kim Callanan with the Compassion and Choices Action Network. There's no time frame for how long someone has to be within a state. It's really about whether you have an ID, a government ID, voter registration, all the normal ways that you would establish residency. But the reality is, there's two really important things to keep in mind. The first is that your bordering states of Oregon and California already have this as an option, and we now have 1 in 5 Americans. So the idea that Nevada will become like a suicide mecca for this is highly unlikely, both because you're seeing so many other states adopt this as an option, but in addition to that, people at the end of their life, they don't have the wherewithal, the means, the physical ability to pick up and move. So people choose this option because they want to be able to die at home surrounded by their loved ones, and very, very few people have the wherewithal and are able to just pick up at the end of their lives after getting a terminal diagnosis, be able to reestablish residency someplace, and then be able to go through the 13-step process in order to access the law. So in the history of it being authorized across all of the states, there are a couple of examples where people have successfully moved to a state in order to access the option, but it's few and far between.
And final question is, you choosing the age of 18 versus say 21 as a brain matures, et cetera. Have you seen and actually the age difference in who actually requests this medication?
Kim Callanan with the Compassion and Choices Action Network. When you look across at the data across all of the authorized states, generally speaking, you're seeing it be older people that are accessing the option. The average age, I'd have to pull it up and see if I can quickly find the average age. And I don't know, Peg, do you remember the average age offhand?
This is David Grube in Oregon, and the average age has always been over 70. The exceptions are generally the neurodegenerative diseases like ALS. That is almost the only diagnosis for younger people. But the average age is over 70 each year.
Thank you, Madam Chair, for the second line of questioning. And that's all. Thanks.
No problem. And before I start testimony in support, I'm taking a look around here to see if I have any other questions from committee members, and seeing none, I'm going to start with testimony in support. I believe we have at least one person I see on here to testify in support. Again, I'd remind people testifying in support to please clearly state your name before the record and limit your testimony to 2 minutes. Although I have given people that are on the Zoom link some additional leeway in their testimony, but keep in mind that it will take away from the testimony that we go to on the phone line. So at this time, I see Senator Parks you can go ahead and unmute yourself and introduce yourself to Assembly Health and Human Services, and welcome back. And go ahead with your testimony and support when you're ready.
Thank you, Chair Wynn and Vice Chair Peters and Health and Human Services committee members. For the record, I'm David Parks, and I support the passage of Senate Bill 351, sponsored by Assemblyman Edgar Flores. For the last 3 legislative sessions, I requested legislation on the issue of medical aid in dying. I brought legislation forward as a promise to a dear friend who, at the end of her life, pleaded with me to introduce a bill that would mirror Oregon's Death with Dignity Act. She would have relocated to Oregon to avail herself of its legislation had her health allowed her to make the move. During the time that I have pursued this legislation, I have been asked by people from across Nevada, from many different legislative districts, to pass this legislation. Some were cancer patients who wanted to have the peace of mind knowing they can control their final days. Others wanted the assurance that after exploring all traditional options, a legal, safe, and peaceful option would be available to them to control the end of their life on their own terms. Please support Assembly Bill 351. Thank you for the privilege of your time.
Thank you, Senator Parks, and it is a pleasure to see you back here in the virtual legislative building. And with that, I think that is the only caller and support that we have on the Zoom link. So at this time, if I can turn this over to Broadcast Services to go to the callers on the line in support of Assembly Bill 351. Again, I would remind callers to please clearly state your name for the record, spell it if necessary as well, and limit your testimony to 2 minutes. Again, I would encourage everyone to please reach out within 48 hours if you have additional written comments that you would like to provide to the committee for consideration in assembly, either support or opposition of Assembly Bill 351. I know that one of our own Assembly members, Assemblywoman Black, has reached out and had a lot of constituent outreach regarding Assembly Bill 351. And so I would encourage those people that have participated with her outreach to also directly reach out to the legislative website to submit that documentation. And with that, if we can go to Broadcast Services to begin testimony and support.
One moment, Chair.
Take your time, we're patient.
Just one more minute, Chair.
No problem, America.
Can you hear us now, Chair?
I can hear you. Can you hear me?
Perfect. I can. Thank you. Caller with the last 3 digits, 080. Please start your testimony over again. And slowly state and spell your name for the record. You have 2 minutes and may begin. Caller with the last three digits 080, please press *6 to unmute.
Thank you, Madam Chair and members of the committee. For the record, my name is Susan Fisher, SUSANFISHER with McDonald Corano. I represent Death with Dignity organization, but I'm speaking today on behalf of a friend. And I thank Assemblyman Flores for picking up the torch on this important issue and for introducing AB 351. During the 2015 session, I was working on Senate Bill 336, which was a bill similar to what you have before you today. In the course of the session, I met a woman who lives right here in Carson City who's been suffering with cancer for many, many years. Her name is Debbie Black. And in the exhibits, you will find a guest column recently written by Debbie and printed in the Reno Gazette-Journal. She has the best attitude toward life and has an amazing sense of humor, and I rarely see her without a smile on her face. Debbie couldn't join us today because she's spending what will probably be her last visit with her three sisters who all live in different states. Debbie asked that I relay her story and urge you to support AB 351 for her. She's not in a hurry to die. She was first diagnosed with breast cancer 29 years ago when her son was just 6 months old. She fought it then, surgery, radiation, chemotherapy, and she did pretty well for the next 20 years until she was diagnosed with breast-to-brain cancer. That tumor was removed, but she lost most of the use of one side of her body. Lots more rounds of chemotherapy, years of physical therapy, and she regained both the use of her arm and leg for the most part, and more importantly, gained more years of hope. This past August, she had a craniotomy to get to a new mass in her head. It was a metastatic brain tumor. They were not able to remove it. She couldn't have visitors due to COVID, so she sent me photos of the huge swath of bare scalp covered with metal staples and the dent in her skull where the bone had been removed. It was estimated in early September that she had 10 to 12 months to live. Do the math. She asked me then if we could hurry up and get this bill passed within that time so that she could control the end game. I told her I didn't think we could get it done that fast, but we'd try. Her son and granddaughter live here in Carson City. She doesn't want to leave them, but she will leave this world anyway, one way or the other. She has considered setting up residency at a friend's home in California where Death with Dignity Act has been in place since 2016. And she's asked me to be there with her to help make her laugh right up to the end. She told me just last week that her doctors think there's a new mass in her brain. We don't know what it is yet, but they think it may be necrosis, dead brain tissue. Debbie Black doesn't know if she would actually use this act and the medication to end her life, but she wants this option because her other options have all been taken away, including the option of living. I thank you, and Debbie thanks you for your time and consideration of AB 351. Thank you.
Thank you, Ms. Fisher. We can go to our next caller in support.
Caller with the last three digits 199, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you, Chair and members of the committee. For the record, my name is Tess Opferman, spelled O-P-F-E-R-M-A-N, speaking on behalf of the Nevada Women's Lobby. We appreciate the emotional testimony that has been presented today. End-of-life care decisions are difficult for everyone involved, families, children, parents, and these decisions are even more difficult when someone is dealing with unbearable pain and suffering. AB 351 gives the option for compassionate end of life, allowing someone with 6 or fewer months to live the opportunity to make informed decisions with their family and friends to escape pain and suffering. This is about human dignity. The Women's Lobby is in full support of this bill, and we sincerely thank Assemblyman Flores for his compassion dealing with this challenging topic. We urge the committee to pass AB 351, giving Nevadans the option to choose. Thank you for your time.
Caller with the last three digits 725, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you, Chair Wynn and committee members. This is Nick Shepak, Nickshepak, on behalf of the ACLU of Nevada. I want to start by thanking Assemblyman Flores for his impassioned and very real testimony. I want to let him know that I feel you. We recently lost my aunt to pancreatic cancer, and it was one of the most brutal and violent and aggressive things I've ever had the misfortune of witnessing. The fact that she lived in a state where she had access to this type of life-ending medication brought comfort to her, to my grandmother, to my family that she would not otherwise have had in that and at that point, towards the end of her life there, she did not choose to use the medicine, but the option made all the difference. The right of individual autonomy protects people's constitutional right to control their bodies and to make end-of-life decisions. There is value in having aid in dying that is legal and transparent. States with bans have tolerated gray markets where people with resources can find sympathetic doctors to give them medication, but those with limited resources often use self-induced means that fail. When the process is open and transparent, it can be regulated and we can keep people safe and keep track of the process. End-of-life choices are already recognized and accepted legal practice. Competent adults' unqualified legal right to decline medical care is accepted with clear and convincing evidence exists that the patient wishes to end life support and through advanced directives. Finally, aid in dying laws open communications between the doctors and their patients to promote the right of the person to choose to keep living. The statistics from Disabilities Rights Project show that 1 in 25 patients who ask a physician about aid in dying actually request the medication. Because the patients and the physicians can speak openly about end-of-life options without fear of criminal liability, those patients are free to discuss their fears more openly and seek alternative options. For these reasons, we strongly support this bill. We encourage you to vote yes. And again, we thank you for bringing this bill on behalf of anyone who has watched someone struggle through the end of life. Thank you.
Thank you. If we can go to our next caller in support.
Caller with the last 3 digits, 285. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
My name is Paul Klein, Paulklein of Tri-Strategies on behalf of Compassion and Choices. First, Assemblymember Flores, I truly felt your passion, conviction, and values today, sir. I feel incredibly lucky to have your representation at the Nevada Legislature. Committee members, we really appreciate your consideration of this bill today and the thoughtful questions you asked thus far. While you continue to evaluate this bill, I wanted to point your attention to a poll conducted just a few days ago that resulted in 72% of Nevadans supporting this legislation. That's nearly 3 in 4 Nevadans. Most notably in this poll, from political party affiliation to religious affiliation to age, race, gender, and more, every single demographic group supports this legislation. Therefore, if you're content with the criteria, if you're content with the safeguards of the bill, but your personal view is unsure, please know that the Nevada electorate, your electorate, by a vast majority, supports this bill. Thank you.
Thank you. If we can go to our next caller in support.
Caller with the last 3 digits, 015. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Yes, good afternoon. For the record, Fred Volz, V as in Victor, O-L, T as in Tom, Z as in Zebra. Several of this committee's members are either lawyers, medical doctors, work in the helping professions, or have science training in their backgrounds. They are oriented toward problem solving. Unfortunately, an incurable disease does not have a solution. Worth noting, most of this committee's members are of a younger age where they probably have not personally experienced the horrific illnesses family, friends, and colleagues face, typically in the later years of life. Just as each one of us holds varying views about religion, any one religion's beliefs should not be imposed upon the individual or society at large when facing an existential decision about personal illness where there is no hope of recovery. Machines, drugs, therapies, and other technology can keep someone alive in the technical sense for a considerable amount of time, despite the human body being ravaged by a disease, pain, or hopeless medical condition. Taken in its totality, this legislation offers multiple safeguards against abuse of its provisions. However, one area needing further clarifying language is in the life insurance realm of sections 42 and 43, as Assemblywoman Titus brought up. It is concerning that someone could purchase life insurance that might not require underwriting just before taking the death-inducing substance in a last-ditch attempt to financially benefit their family, heirs, or charities. Insurance companies would likely hike premium requirements on everyone else insured by that company to recover the prospective losses of too few premiums and too many benefits paid out. Thank you.
Thank you. If we can go to our next caller and support.
Caller with the last three digits, 364. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello. Thank you, Madam Chair. My name is Kathleen Bohall, B as in baby, OHALL. I am in support of Assembly Bill 351. The Nevada End of Life Options Act is not murder, nor is it suicide. It's a plan for the eventuality of death, which we all face. We don't wait until the moment of birth of a child to plan for it. We spend 9 months, sometimes years, preparing for that event. I'm not afraid of death, but I am afraid of the dying process. I had twin aunts who lived in California. One aunt died of congestive heart failure at the age of 90 in 2017. Her twin sister was at her side and had to watch her agonizing death. 3 years later, my surviving aunt was dying of the same diagnosis. She chose to utilize the California End of Life Options Act. The relief and joy she experienced once she was authorized to use this option was remarkable. I shared that relief, all the while dreading her death. I moved to Nevada in 1962, almost 60 years ago. Nevada is my home, and I want to die in Nevada. But I plan to move to a state which allows end-of-life options if and when I am diagnosed with a terminal illness. I urge all lawmakers to research the process of a death from congestive heart failure before you deny this alternative. Every mentally capable adult with 6 months or less to live should have the choice to request from their doctor a prescription they can take to avoid unbearable suffering and die peacefully. Please support Assembly Bill 351. Thank you.
Thank you. Broadcast, we can have the next caller, please.
Caller with the last three digits, 776. Please slowly state and spell your name for the record. You have 2 minutes and may begin. Caller with the last three digits, 776. Please press star 6 to unmute.
Good afternoon, Chair Nguyen and other committee members. My name is Dar Stone, D-A-R, my first name, Stone, S-T-O-N-E. I live in Assembly District 41. I appreciate being allowed to come before you to speak in favor of AB 351 today. I have been a physician assistant for 38 years, with the last 27 being here in Southern Nevada. Before that, I was a registered nurse and commissioned officer in the United States Public Health Service. I have attended bedside with patients and their families at the end of life, and it has all too often been fraught with pain, suffering, and intense anxiety for the patient and their families. Medical aid in dying is not assisted suicide. It is not out of depression that a terminally ill patient may want to end their life. They simply want the option to die peacefully. It is not for everyone, but it is a choice. And for those concerned that this decision may be impulsive or coerced, these concerns have simply not been borne out of the evidence gathered over the last 2 decades in states where this has been legalized. There are strong safeguards in place in this bill to prevent abuse, coercion, and impulsivity. None of us who work in healthcare question a patient's right to informed consent. It is the backbone of our virtually unanimous belief in patient autonomy, the right to elect or forego a medical intervention. This logic should extend to the rights of a patient to control the circumstances of their death. It is simply humane and compassionate when suffering is refractory, when hospice care has done all it can do for a person suffering from an irreversible terminal illness, that the patient be allowed to ingest a lethal medication to end their suffering if that is what they choose. I urge you to vote in favor of AB 351, and I appreciate this opportunity to speak with you. Thank you.
Thank you for your comments. Broadcast, do we have more callers in support?
Yes, Chair. Caller with the last three digits, 691. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you to Chairperson Nguyen and the committee for allowing me to speak. My name is Kim Mazeres, K-I-M-M-A-Z-E-R-E-S, from Reno, Nevada. I am speaking today in support of AB 351. My husband was cognizant until his very last hours. He knew he wanted the option to decide for himself when enough was enough. Steve passed away in June of last year after suffering chronic rejection due to a lung transplant. However, he and I had many conversations about his wishes, and those included a potential relocation to Oregon in order for him to control the end of his life. Steve suffered from COPD, chronic obstructive pulmonary disease, and we discussed medical aid in dying both before his transplant and after. My husband and I spent more than 30 wonderful years together. A veteran who late in life became an attorney employed by the DA's office, Steve was diagnosed with COPD when he was in his 50s. After an exacerbation and a failed surgery, doing nothing or having a transplant were his only options. Steve brought up the idea of moving to Oregon so that he could utilize their medical aid in dying law. I was mad that we might have to uproot ourselves to establish residency in a state where we have no family, a place that was not home for either of us. Steve ultimately opted for the transplant, and he did really well for a year, but something kicked off chronic lung rejection. He opted for treatment of the rejection, but it did not work for him. Steve's last 24 hours were horrific. He was in a tremendous amount of pain, and I scrambled to get him enrolled in hospice. As it turned out, assistance from hospice was perfect. Steve passed only 5 hours after starting on service with them. But what would have happened if it had been a weekend with no hospice intake staff available, or I'd have been unable to make that happen for him? If we had the option of medical aid in dying in Nevada, my husband could have chosen whether or not he wanted to avail himself of that option. Terminally ill adults should have the choice to shorten their burden of suffering at the end of their life. You pass AB 351 to give all Nevadans this choice. Thank you for your time.
Thank you. And I'm going to go to our next caller in support.
If you've recently joined the call and would like to testify in support of Assembly Bill 351, please press *9 now to take your place in the queue. Caller with the last 3 digits, 555, please slowly state and spell your name for the record. You have 2 minutes and may begin. Caller, you are unmuted on our end. However, you may be muted on your phone.
Hello?
We can hear you.
You can. Okay. Sorry about that. My name is Dan Diaz, D-I-A-Z, and I am Brittany Menard's husband. Brittany died on November 1st, 2014. She was only 29 years old. Brittany experienced a gentle dying process only because of the option of medical aid in dying. Yes, my wife utilized the very program that we are discussing here today. I am testifying in support of AB 351. Brittany was determined to live as long as possible. She endured an 8-hour brain surgery. We researched every treatment option that was available. Unfortunately, the cancer was growing aggressively. This program allowed her to truly live the time that she had left and then experience a gentle death. Brittany's case received significant attention because at the time we had to move from our home in California so that she could access Oregon's law. Had we stayed in California, the brain tumor would have continued to torture her to death. People in Nevada deserve better than that. No one should ever have to leave their home like we did. With 72% of Nevadans agreeing with Brittany that a terminally ill individual should have this option at end of life, I hope this HHS committee reflects that support from your constituents as you vote in favor of this bill. Furthermore, as a Catholic and as a Latino, I take great pride in the fact that 70% of Catholics nationwide also agree that this option should be available to terminally ill individuals who qualify. I have spoken with several of you personally, and please keep in mind that Brittany simply took control back from that cancer so she would not have to suffer. The opponents' campaign is based on fear. They use inflammatory words like suicide and euthanasia in their attempt to scare legislators and the public. But to be very clear on this very protective option for terminally ill individuals, it does not result in more people dying. It simply results in fewer people suffering. Thank you.
Thank you. I believe we have maybe one more caller on the line, and go ahead when you're ready.
Let's check. Caller with the last three digits, 753. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hi, my name is Dr. Claire Johnson, John-S-O-N. Thanks for letting me join today. I'm an emergency medicine physician living in Reno. As an ER doctor, I see patients at the peak of their suffering, often in the last 6 months of life. I have seen patients lose the ability to eat as stomach cancer has progressed. I've seen 6'2" men at only 130 pounds at the end of months of chemotherapy. It has become evident to me, with great medical advances, we have created great suffering. I believe it is our moral imperative as a society to give options that alleviate this suffering. I started my career in a state without medical aid in dying, Georgia, and later worked in a state with medical aid in dying, California. A coworker in California recently lost a family member after a 3-year battle with metastatic cancer. This family member opted in for medical aid in dying at the end of her life. She had control over the end of her life and was able to die in the comfort of her own home with multiple family members present. She was one of the 405 terminally ill people in California in 2019 who chose this option. Many of you here today may not want to exercise this option, or this option may go against your personal belief system. I respect that and celebrate that we have different views. However, we owe it to our diverse state to provide people with diverse options at the end of life. I strongly support AB 351. Thank you all for your time.
Thank you. And that was the last caller that we had on the line in support of Assembly Bill 351. And I think we are at about 23 minutes. Sorry, so close. And at this time, I will begin testimony in opposition of Assembly Bill 351. I do have three individuals, 2 on one Zoom, that are on the Zoom. So I am going to start with them. I will ask them to unmute and I will call them and by name, just so we can make sure that we get them on here. I'm going to start first with, we have 2 disability advocates on the line, Brianna Hammond and her mother, Deidre Hammond. They are both on the Zoom. So I will ask you guys to please unmute when you are ready and turn on your camera. I see that you've done that. And again, I will ask you to limit your testimony to 4 minutes today, please. And we won't begin that until you're able to start on. I know that you are using the assistance of a machine to speak, so are we ready on that end? I think you need to unmute if you can hear me.
Chair, I believe they're working from a small device, so it might take them a moment.
We will be patient.
Should we go now or should we wait?
We can hear you. Go ahead and go when you're ready. We'll begin your 4 minutes now.
Thank you.
Oh, okay. My name is Brianna Hammond. I am an international disability advocate born and raised here in Nevada, speaking in opposition. Please note, I have an incurable and irreversible condition that cannot be cured or modified by any known current medical therapy or treatment. In fact, I have several They're called disabilities. So even though the bill cleverly does not say the word disability, there I am. All you need is an opinionated doctor to make a subjective pronouncement of my imminent death, which many would be very willing to do. And I meet the definition of terminally ill. I'm amazingly healthy, but I am at risk here. All ideas, including assisted suicide, are utopian, full of safeguards and happy, rich white people who are used to having control over their health care. But reality is chaotically haphazard and even violent, especially for people with disabilities and the elderly who live in poverty and even middle incomes. People with disabilities very often do not even receive suicide prevention counseling for depression. Did you know that? We show signs of wanting to give up or have suicidal thoughts. Attitudes and access barriers can make us lonely, but no one tells us about counseling. They tell us about death. What kind of message is that? Disability you are born with is just who you are. I do not want to be you. I want to be me, disability and all. And for people who acquire a disability, we are talking about conscious, sentient human beings who need time to adjust to limitations and overcome obstacles. Assisted suicide's push fails to allow that time. I need you to understand that if the only alternative to death that those in power offer people who require assistance is poverty and segregation in nursing homes, then it makes no sense to talk about assisted suicide as a choice. Because according to the Oregon statistics, the number one reason that people choose assisted suicide is not wanting to be a burden. No one even tells them about attendant support and all the other myriad of support that help us stay connected to community. I think it may be hard for you to imagine what it is like to seek medical services as a person with a disability. I have a very hard time getting many medical professionals to listen to me. It is like they have a script in their head about the poor disabled girl, and they assume they need to make decisions for me. I explained to a doctor that I have a significant gag reflex and would need sedation for a procedure, but he kept ignoring me and assuring my mother I was not a behavior problem. Many professionals are as uncomfortable around me as the general public. Because I have the Stevie Wonder head bob, people prefer to talk to the people I am with who have an easier time making eye contact. Family members have so much influence in the medical field, and not all of them want what you want. Well, meaning doctors look at me and think I would be better off dead. They will think it's a favor to offer to suicide me. Over and over again, I will be educated about my right to die. Do you know what it is like to be told you should suicide? You should fill out paperwork to end treatment. You should have a DNR. Everyone wants to educate me. No one wants to tell me my life is worth living. If you pass this bill, you make it law. You make it worse.
Thank you for your testimony. At this time, I will go to Dr. Brian Callister, I think is also on the Zoom. I remind you again to please state your name for the record and please limit your testimony to 4 minutes.
Thank you so much, Madam Chairman and members of the committee. I appreciate being here, and this is such an emotional, tough subject, and my heart goes out to Assemblyman Flores and all of you that had to experience this. I'm here to let you know that there are perverse negative consequences that you need to consider with this legislation. It sounds like everything's going swimmingly well in Oregon. That's not exactly genuine or legitimate. I got involved with this a few years ago when I had two patients, Nevadans, in our hospital, who one was visiting and then going back to Oregon and one was going to California. And they both had serious illnesses that would be terminal without treatment. Both patients had a potential for cure, a significant chance of cure with a standardized medical regimen. I referred one of these patients to Oregon, one to California. And when this came up, in both cases, the insurance medical director, of course not writing, they're not that dumb, on the phone in both cases said to me, Brian, we're not going to cover the treatment or the transfer, but hey, by the way, did you talk about assisted suicide? Did you bring it up? I was stunned. I absolutely couldn't believe it. And of course, when I called them out on that, their response, and you've heard a little bit of this earlier, their response was, oh, there's no correlation. And you heard some of that today. No correlation. They deny treatments all the time. They approve treatments all the time. And they just happen to deny a life-saving standardized treatment and ask if we offered this up. That's what got me involved in this. And in fact, when you talk about the potential for coercion and abuse, you have to understand that as physicians, we are very poor at predicting life expectancy with a terminal diagnosis. Today, I've been listening, and it sounds all so precise. Oh, I'm a doctor and you have 6 months to live. You know what? Our average error in the medical literature in predicting how long you have is 50 to 70% off. So we're very good at giving you a diagnosis. We're very bad at predicting how long you have, and most importantly, how good a quality of time you may have left. And once you get to the end, you know what? Yes, we need more effort in palliative care and hospice, and they're working well in other states. But this falls in the category of kind of throwing out the baby with the bathwater. And to address Assemblyman Thomas's concern, especially with communities that have limited access to health care, that have been marginalized, disenfranchised, people of color, people in poor neighborhoods. How do you know, and you don't, and this is what I'm afraid of with my two insurance cases, that people are not being denied standard medical treatments because this is now called a medical treatment. Killing someone with a prescription is called a medical treatment, and it gives the insurance companies the cheapest option, the chance to offer that up instead of a standardized treatment. And it's happened to me twice. Some of the compassion and choices people have said in the past, oh, there's no proof of that. Let me get rid of that right now. My senior resident at the time backs this up. You can look at the Washington Free Beacon, June 5th, 2017. There's an article all about corroborating this story. You get to the fact that there is a suicide contagion. In answer to the other question about suicide rates, in the first 15 years since the Oregon assisted suicide law was passed, the national rate of suicide went up by 23%, and that is sad. The Oregon rate of increase in general suicide was 48%. And because there's no witness required at the very end, what's to keep Granny, who's being told by her freeloading grandson and girlfriend, your life isn't worth living, to go get the prescription, go home, and who knows if the pill was forced on Granny? They say there's no evidence of abuse, but there's no requirement for investigation.
Dr. Callister, you are right at 4 minutes. If I can get you to wrap up. If you have additional comments, please.
No, thank you. And I will finish up right here. You know, the real story here, especially how it affects other communities, is when does your right to die become some other person's duty to die? This is not a medical treatment. This is assisted death. Let's make that very clear. I thank you very much, all of you, for your time, and I'll be happy to hang around and answer any questions as they come up.
Thank you. Broadcast services, that we don't have any other callers on the Zoom. If we can now go to the phone lines and begin testimony in opposition of Assembly Bill 351. Again, I will remind callers that we have a limited amount of time to do your statement. So I know this is a very emotional thing, so please state your name clearly for the record, and also What was I going to say? Limit your testimony to 2 minutes. And with that, we will begin.
Testify in opposition to Assembly Bill 351, please press *9 now to take your place in the queue. And it has come to my attention that we may have missed a caller in support. If you can please submit your testimony in writing so that the Assembly can look it over, that would be very helpful. Thank you.
Thank you. And I know sometimes that happens. Broadcast Services, thank you for bringing that to the attention. And again, if you are not able to testify in support or opposition or neutral today on the today's bill, you always have within 48 hours to submit those written comments.
Caller with the last three digits, 099. Please slowly state and spell your name for the record. You have 2 minutes and maybe.
Madam Chair, my name is Kathleen Rossi. I'm a registered nurse who has worked in Nevada for over 34 years, and I have much experience in end-of-life care. I'm opposed to this legislation because it is rife with flaws and it will bring unintended consequences. The phrase that hard cases make bad law could never be truer than here. It will change the standard of care when it makes assisted suicide, quote, medical treatment. Suicide has never been a medical treatment, and one certainly does not need a physician to overdose with pills. To act like assisted suicide does not change attitudes of physicians towards medical care options is naive. I'd like to quote Wesley Smith, a bioethicist, when he says, advocacy for legalizing assisted suicide is always couched in terms that would limit access to those who are terminally ill. But given the philosophical and ideological principles that underlie the assisted suicide movement, that autonomy is paramount and ending life is a valid answer to human suffering, restricting assisted suicide to the dying becomes utterly illogical. After all, many people experience far greater suffering and for a longer period of time than people who are terminally ill. Thus, should the two fundamental premises of assisted suicide become generally accepted by a broad swath of medical professions and among the public, there is little chance that this permitted suicide would remain limited to the terminally ill. We do see this in the Netherlands and in the documented cases of suicide contagion, and I see that almost every state that has passed assisted suicide goes on to expand and progress those laws in future years. As a nurse, I've also noticed that it often isn't the patient that can't handle the terminal suffering. It is the family, and often the family that doesn't understand the dying process in general. I also note that many end-of-life dying processes, like heavy breathing that occur and are normal, are not evidence of pain, but are extremely distressing to family members. We need to do more education about hospice and end-of-life with family members. We have gotten so much better at end-of-life care since I started in
can
nursing.
I go ahead and get you to wrap up? You are right at 2 minutes, so if you can wrap up, and please submit any written comments that you have to supplement your testimony today.
Okay, I would just say that this will change medical options by making this medical treatment, and resources should go to continuing the improvement we see in hospice care and not in allowing assisted suicide.
Thank you for your testimony in opposition. If we can go to our next caller in opposition.
Caller with the last three digits, 905. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you, Madam Chair, members of the committee. My name is Mary Fetchner, F like Frank, ECHNER. I represent myself, and I urge you to vote no on Assembly Bill 351. Physician-assisted suicide is an extremely complex subject. It demands careful thought and consideration of the many issues at stake. I'm currently holding a copy of the proceedings of a 2-day workshop hosted by the National Academy of Sciences, Engineering, and Medicine in Washington, D.C. in 2018. The workshop, entitled Physician-Assisted Death, Scanning the Landscape, included 40 experts in the field of palliative medicine, aging, end-of-life, bioethics, hospice care, law, veterans affairs, serious illness care, theology, epidemiology, medical ethics, health policy, special needs, Medicare, Medicaid plans, employee health programs, clinical psychiatry, philosophy, medical doctors, and practitioners. These experts presented their findings based on their research and experience. They published a 165-page summary of their findings. Rather than a cursory consideration of public testimony, which I've found there are some inaccuracies and some lack of the basic general knowledge of how this bill works in Oregon, which is very concerning. So I urge you to research this very complex issue and its ramifications before making your decision. And rather than concentrating your efforts and our tax dollars on ending the lives of our citizens, please direct them towards preserving life and providing loving palliative care at its end. Nevada citizens will thank you for it. I just also wanted to bring up that
you are at 2 minutes now. If I can get you to wrap it up, if you have additional comments, please submit those in writing at the legislative website.
Okay. I just wanted to say that Ms. Callahan has been quoted in 1919 as saying, if lawmakers want to improve medical aid in dying laws, then let's address the real problem. There are too many regulatory roadblocks.
Broadcast
already.
services, can we go to the next caller, please?
Caller with the last three digits, 464. Please slowly state and spell your name for the record. You have 2 minutes and may begin. Caller with the last three digits, 464. Please press *6 to unmute. Caller with the last three digits, 302. Please slowly state and spell your name for the record. You have 2 minutes and may begin. Caller, you are unmuted on our end. Have you muted yourself on your end?
My name is John Kelly. I am the director of Second Thoughts Massachusetts Disability Rights Advocates Against Assisted Suicide. I agree with everything Brianna Hammond said. Bills like these promote prejudice against our lives because we depend on others for our care. The messages that our lives are worthless are endless, and this bill promotes that prejudice. Bill AB 351, like all assisted suicide bills, takes away individual choice and gives it to insurers who care more about money than people, who care more about money than people. Dr. Callister speaks the truth. We cannot trust insurers to do the right thing rather than the cheapest thing. Proponents say there has never been a case of abuse, but that is absolutely false. Please do a search for Wendy Melcher, a very ill trans woman who had not applied for assisted suicide. 2 nurses tried to kill her with massive amounts of morphine, and she died a few days later. There was no criminal referral to authorities. The Oregon Nursing Board dealt with the matter in secret, and the nurses received light discipline. There are many other cases that have been documented. I thank Dr. Titus for bringing up the impossibility of accurate prognosis. As she said, people can live years longer than 6 months, like the 12 to 15% of people admitted to hospice who outlive their prognosis. What about these people? Do we care about them? Please do a search for Jeanette Hall, who's been alive 20 years after she sought assisted suicide. She was persuaded to try more treatment, and now she is active against these bills. Assisted suicide means that people who would otherwise be happily alive are now dead. And assisted suicide is just too dangerous. Please vote no. And no matter what they say about safeguards, the Public Health Department has no authority nor resources to investigate any
Sir,
problems.
you are at 2 minutes right now. If I can, excuse me, sir, you are at 2 minutes right now. So if I can get you to wrap up in the next couple seconds, and please submit your testimony if you have additional comments.
Assisted suicide says that some people have dignity and some people don't. It's divisive and must be defeated. Thank you.
Thank you for your testimony. We can go to our next caller in opposition.
Caller with the last 3 digits, 703. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair and members of the committee. My name is Felipe Avila, President of Team Pro-Lifers. Team Pro-Lifers is an international youth organization composed of exceptional high school and university students working to advance the pro-life cause worldwide. It's truly astounding to hear Assemblyman Flores advocate for ending human life in such a casual form. Assisted suicide gives insurance companies and governments the ability to save money by pushing lethal drugs that are less expensive than treatment. No trained medical personnel are required to be present at the time the lethal drugs are taken or at the time of death, creating the opportunity for an error or abusive caregiver to coerce the patient to take the deadly drugs or put them in the patient's food without the patient's knowledge or consent. There is no requirement in the bill that the patient, in order to receive lethal drugs, be facing a terminal disease that would take their life in 6 months. For those in difficult circumstances, the correct responses are encouragement and assistance, not an argument in favor of their death. People dealing with depression in the face of illness, injury, or impairment need those around them to affirm their value rather than advocating for a quick end. People targeted for assisted suicide are often people of color like myself, who often lack the resources to pay for medical care. This discriminatory bill will result in a bigger inequity gap between income levels in the state, favoring the wealthier who are able to afford such treatment. As people near the end of their lives, realistic, humane treatments and compassionate care are essential. We can and should support options such as hospices and other measures that help provide comfort to people in their last days. However, intentionally killing someone can never be compatible with an ethical worldview. Please vote no on AB 351. Thank you for your time.
Thank you. I know we have some callers that had some difficulty turning on, so it may seem like we are going a little bit over the time in opposition, but I am going to take one last caller in opposition. Broadcast Services, if we can go to that last caller.
Caller with the last 3 digits, 464. Please slowly state and spell your name for the record. You have 2 minutes and may begin. Caller, you are unmuted. Go ahead, we can hear you.
This is Dr. Fennick. I'm not sure I'm the right person. I didn't hear the number to call.
This is testimony in opposition. Are you testifying in opposition of Assembly Bill 351?
That's correct.
Please state your name for the record. Go forward with your testimony, and again, limit it to 2 minutes.
Dr. Peter Fennick, F Foxtrot, ENWICK. I'm a family practice physician of over 50 years, at present a professor at UNR Medical School, seeing patients and teaching students. I've practiced at times in 4 countries, England, Scotland, Anguilla, where I was the only physician, and the USA. I oppose AB 351 for several reasons. I took the Hippocratic Oath, which categorically states I will give no deadly medicine to anyone if asked or suggested. As a family practitioner, my patients have become my family. I have treated literally thousands of patients and hundreds of patients with terminal illnesses, and never needed to subject anyone to a form of assisted suicide. I also have never let anyone suffer, as I've always been able to treat any untoward symptoms successfully. It is important when a patient is in the terminal stages of life to handle the patient's medical and psychological state, and this includes the family. To introduce assisted suicide as a topic would be harmful to all concerned. When I worked in emergency rooms in London and Reno, I saw several people who were brought in having taken overdoses, and those that were not comatose were suffering severe physical symptoms. Do we really want to subject people to a kind of death when I can treat all their symptoms of illness and experience a normal death, which also helps the family in the situation? The very fact that the patient must administer the medication and the physician must basically not be there infers that the physician is not responsible. This is terrible. Section 25 states that taking a prescribed overdose is not suicide, though the whole procedure is titled assisted suicide. If handing a patient a handful of pills to kill themselves would be okay, is it okay to hand them a gun which could cause instant death and not necessarily a slow death? Sections 1, 2, and 3 state that the physician must not state the true cause of death.
Doctor, you are at 2 minutes right now. I need you to wrap up your testimony. If you have some written testimony, please submit that in writing.
Yeah. So the doctor must falsify the certificate to state the patient's illness is the cause of the death. The actual cause of the death is the medical overdose, which must be left off the certificate. The death certificate should be 100%
services,
true.
if we can stop testimony at this time. Thank you. At this time, I will turn the hearing back over to Assemblyman Flores for any closing remarks. I don't know if you or your presenters have any closing remarks to make at this time.
Thank you, Madam Chair. I won't be too long. I just wanted to say...
You know what? I'm sorry. I got to go to neutral testimony.
Oh,
I'm coming back here. Broadcast services, if we can now go to neutral testimony. I don't see anyone on the Zoom. If you are on the Zoom and you are here to present neutral testimony, if I could ask you to unmute and turn on your camera. I'm looking. I don't see any. Oh, wait, I see. Ms. Rodriguez, are you testifying in neutral?
I am, Chair.
Okay, I would have you begin your neutral testimony. Please state your name and limit your testimony to 2 minutes.
Perfect. Thank you, Chair and Committee, Jamie Rodriguez, JamieRodriguez. I'm the Government Affairs Manager for Washoe County, and here to testify in neutral. Wanted to thank the bill sponsor and the proponents for agreeing to accept our amendment. The purpose of our amendment was to create clarity and ensure the roles of the different participants in the process, wanting to make sure that who is going to be signing the death certificate, treating this much more like hospice so that these cases would not come to the coroner or the medical examiner, requiring us to do a full autopsy and sign off on those death certificates. So that's really the purpose of our amendment. And just again, really want to thank the bill sponsor and the proponents for working with us, understanding our concerns and accepting our amendment. Thank you, Chair.
Thank you. Do we have any other people on the Zoom that are here to testify in neutral on Assembly Bill 351? If you are, I'd ask you to please unmute and turn on your camera at this time. Seeing none, broadcast services, can we now go to the line in neutral? I will remind callers that this is neutral testimony. This is not in support. This is not in opposition. This is neutral testimony of Assembly Bill 351. Again, if you did not have the opportunity or you came on late or you didn't get to submit your full comments, I would encourage you to submit those comments in writing within 48 hours of today's hearing on Assembly Bill 351. Broadcast services, can we begin testimony in neutral?
To testify in neutral to Assembly Bill 351, please press *9 now to take your place in the queue. Caller with the last 3 digits, 319. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Madam Chair, this is Melissa Clement, MELISSA-CLEMENT. I am just amazed. We had more than 2 hours of testimony in favor. There are some very serious issues with this bill, and there has been insufficient
Broadcast services,
opposition testimony to.
At this time, broadcast services, can we go to the next caller in neutral?
Chair, the public line is open and working, and there are no more callers in neutral at this time.
Thank you. At this time, I will turn this back over to Assemblyman Flores to go ahead and make any closing remarks regarding Assembly Bill 351.
Thank you very much, Madam Chair. Assemblyman Edgar Flores for the record. And I don't know if my co-presenters may have some additional comments, but I did want to respond to some of the folk that called in. And first of all, I wanted to say thank you to everybody who called in. I don't believe anybody who called in either in support or opposition came from a place of wanting to harm Nevadans or do anything like that. I think everybody just came from a very personal, compassionate lens. And so I appreciate them engaging in this conversation. I will say that I don't take this conversation lightly, and that and by no means do I think it's easy engaging in this conversation. Quite the contrary, it was a very difficult conversation for me to engage in. But through my personal experiences, find myself here presenting this bill. I also find it slightly disingenuous that we had so many folk call in opposition talking about this is a bill to harm people of color and poor communities. I think we consistently tokenize people of color and poor communities whenever it's to our advantage, which is why precisely I refused to engage in that conversation, period. It is a political tool that is used consistently. All of a sudden, we're going to be utilizing this medication to kill all people of color and poor people when we don't have necessarily the data to suggest that even people of color are the ones that are engaging in this option to begin with. So it's frustrating to me because it is often a political ploy that is utilized. And I think often they see me, they see a person of color, and just drop these key phrases in hope that they will trigger something not supported by data. So I come before you, Madam Chair, Madam Vice Chair, members of the committee, and engage in a very personal, very complex conversation that we have a whole host of other states are now engaging in that we can use and study and continue to evolve and grow in this particular subject matter. So with that, Madam Chair, if I may ask if our co-presenters have any additional comments, but I will also say thank you to Senator Parks for his advocacy and work in this area. As I mentioned previously, I am simply picking up the work that he has done in the past for us, and I'm appreciative to him.
Kim Callanan with the Compassion and Choices Action Network. Thank you all so much. For the record, I wanted to be sure that I had correctly noted the number of people who had ingested medication. It's fewer than 4,300 people across 9 jurisdictions in about 50 years that have ingested the medication. Somebody suggested I may have added a 0 to the end of that. So if I did, I just wanted to be sure that I had got that right. That brings such profound peace of mind to those people who choose the option. I also wanted to just note that the law specifically notes that people with disability do not qualify. So someone cannot qualify simply because they are disabled. They must be terminally ill with a prognosis of 6 months or less to live. I know how difficult it is. We have so much systemic issues within our healthcare system targeting people with disabilities. This law actually provides a structure and a framework to ensure that they are protected and actually has far more safeguards in place than any other end of life care option that's out there. I also wanted to note that the law, it is illegal for an insurance company to deny health insurance. None of us would want health care to be denied by this becoming an option. And I will say that if that were to happen, that is the kind of court case that Compassion and Choices would take on and litigate, because we want people to be able to have this option, but we also want them to be able to have good medical care. And it is important that both of those things can exist at the same time. I also did want to note that the National Academy of Sciences 2-day conference that was there, I actually attended that and I spoke at it. I walked away from that conference hearing very clearly that the doctors that prescribed and were practicing medical aid in dying, they had a lot of people that came in from California. What they were experiencing was that the law as written had too many regulatory roadblocks in place. And so what we've seen in the states that have authorized is no expansion of the law. It's not that more different people are now eligible for the law, but you are seeing lawmakers begin to grapple with the fact that you have about a third of people who died during the 15-day waiting period, which is something that your bill does address. So that's what the outcome from that conference is, and that's what the statement that the person read that I made was, that we needed to find that appropriate balance. But there's been no expansion of medical aid in dying laws to different populations. They're all designed with that same 6-month prognosis that's tied to hospice care. I could go on because there were so many different provisions, but I know that you've been at this for a long time. So I just want to thank you for really taking the time to consider this bill. And if any of the opposition concerns are things that you remain concerned about, I'm happy to answer questions that people have offline or at whatever point you'd like. Thank you.
Thank you, Ms. Callanan. Assemblyman Flores, do you have any other?
Assemblyman Flores, for the record, Madam Chair, I don't believe that anybody else wishes to make any closing remarks. Just, again, thank you to everybody who engaged in this dialogue, and thank you to all the folk who helped me work on this.
Thank you. At this time, I will close the bill hearing on Assembly Bill 351. At this time, I will open up public comment. I see that there are quite a few people on the line for public comment. I know that this is a policy committee, and a lot of times we will disagree on policy. I would ask people to remain respectful and civil with our rules. They're in there for a place to ensure fairness and the ability to have as many people on the line that we can hear. I will remind that public comment is not a place to rehash the bill that we just heard, Assembly Bill 351. Again, if you have concerns in support, opposition, or neutral of Assembly Bill 351, I strongly encourage you not only to reach out to the bill sponsor, to send emails to the Health and Human Services Committee members, as well as your own state assembly representatives, but you can also submit those comments in writing, and they will become a part of the public record if you do so within 48 hours. With that, we will begin public comment, and at this time, again, I will remind callers to please clearly state and spell your name for the record and limit your comments to 2 minutes.
Participate in public comment, please press *9 now to take your place in the queue. Chair, the public line is open and working, but we have nobody to participate in public comment at this time.
Thank you. Again, I would remind people, I know that this was a very emotional hearing about a very emotional topic, and I would encourage everyone, if you're willing to share your comments, either in support, opposition, or neutral of this bill, to do so in writing at the legislative website. And with that, are there any other comments at this time from committee members? With that, I will adjourn the meeting today. There isn't an agenda up for Friday, but I do anticipate that we will have an agenda on Friday at 1:30, or possibly at the adjournment of floor, if there is floor on Friday. So please keep an eye on your email so we can make sure that we get everyone here when we do come to order. And with that, have a wonderful rest of your afternoon.
Thank you, Chair. And you do.